Namaste and greetings. I, Fiza Mahajan, visiting researcher at IMPRI, Impact and Policy Research Institute, Prabhav एवं नीति अनुसंधान संस्थान, नई दिल्ली, extend my warmest welcome to you all to IMPRI Web Policy Learning. Today we are gathered here for day 4 of Healthcare and Gender Equity, Emerging Dimensions, Policies, Impact and Way Forward, an online international Monsoon School program, a 4-day immersive online hands-on certificate training course. This training program is organized by IMPRI, Gender Impact Studies Center, GISC. The chair for this program is Professor Vibhuti Patel, visiting distinguished professor, IMPRI. This program has an excellent panel of experts who will be sharing their expertise for this 4-day online certification course. The distinguished expert panel includes Professor Vibhuti Patel, Professor Poonam Naik, Professor Uma Kulkarni, and Dr. The conveners for this course are Dr. Vina Vaswani, Director, Center for Ethics, Professor, Department of Forensic Medicine and Toxicology, Yenepoya, deemed to be University, Mangalore, Farhad Yenepoya, Pro-Chancellor, Yenepoya, deemed to be University, Mangalore, and Dr. Simi Mehta, CEO and Editorial Director, IMPRI. Participants would learn from globally and nationally renowned thematic experts and practitioners, gain first-hand insights and networking opportunities, get a course outline and reading list from the experts for learning, get access to session videos for 15 days, receive a certificate of completion, have the opportunity to publish their essays on IMPRI Insights blog, which features articles of eminent people from around the globe. I welcome you all to this enlightening deliberation and thank you for putting your time, energy, and efforts into truly understanding the healthcare and gender dynamics and their intersection in the current scenario. Before we start today's session, I would like to announce the housekeeping rules once again. It is imperative that you join the meeting on time. There will be a Q&A session after each presentation. Share your questions in the Q&A box and not in the chat box. The questions must not be posted as an anonymous attendee. Ensure that your questions are precise and refrain from making general comments in the question to save time. Our session for day 4 will cover topics of gender, health, and human rights by Dr. Amar Jesani, gender and reproductive rights by Professor Uma Kulkarni, and gender justice in forensic medicine by Professor Vina Vaswani. Now, without any further ado, I would request Professor Patel to begin today's session. Over to you, ma'am.
Thank you, Fiza. And first of all, good evening, friends. Welcome to the last day of the course. First of all, let me thank Professor Farhad Yenepoya, Pro-Chancellor of Yenepoya University, Dr. Arjun Kumar, Dr. Simi Mehta, Dr. Veena Vaswani, Vidita Zha, Fiza Mahajan, and Vaishali Singh for putting this course together. Welcome Dr. Amar Jesani and Dr. Uma Kulkarni. The brief recap of what happened, it transpired in the last 3 days. First day 1, we discussed the macro policy issues, healthcare and the gender equity, the concept of equity, equality, gender responsiveness, gender sensitiveness, they were explained. And some of the flagship programs of the government, they were also shared, and the critical reflection on the programs took place. The NFHS 5 data and it's on malnutrition, anemia, they were also deliberated upon, and the WHO guidelines, they were discussed, and special focus was on the health emergency of the coronavirus pandemic and its implications, and how the medical fraternity and the healthcare system responded were discussed. I think the most interesting part was a very, very lively debate and very charged. All the participants were so charged, and the Q&A session also was extremely educative. Ms. Sangeeta Rege's presentation on gender in medical education was also very important, and how the efforts are made to engender the medical education curriculum, and what are the responses that they are getting from the healthcare fraternity. Some of the case studies of dealing with the gender-based violence, or identifying the misogyny or the patriarchal bias in the gender curriculum. Sangeeta Rege gave so many examples, and she also gave very interesting exercises, and also shown the film that how the empathetic way of dealing with the survivors of violence, or any person with health emergency, brings in different kind of result. And it was a very interesting film, and how the change is taking place. She also said that patriarchy is there, but gender relations can be changed by conscious effort. My presentation on social determinants of healthcare and gender equity, that was also dealt with the various approaches, the difference between gender sensitiveness, gender responsiveness, gender aware, and the transformative change that we are bringing through the three ways. One is public policies, other one way is coming up with the very gender sensitive legislations, and also people's participation and decision making, the representation of gender diversity in the decision making process were discussed. Again, that was also followed by a very interesting Q&A sessions. Day 2 of this course that focused on the first presentation by Dr. Sanghamitra Acharya on pandemic, epidemics, and gender healthcare system, brought out the nuanced understanding of how the pandemic had a differential impact on different sections of society, the perspective of intersectionality. I think throughout all the presentations were in the intersectional perspective, and the various different forms of vulnerabilities, how could they be addressed? What are the learnings of healthcare systems' response to the pandemic? They were also discussed by Dr. Sanghamitra Acharya. And Dr. Vala Ramanathan, she acclimatized the participants with the metadata and how to conduct the micro-level research also. How can we supplement and complement metadata with the nuances of the qualitative and quantitative studies? What are the missing links? Where are the gaps? And how can we fill in the gaps that she discussed in the visibility of gender in health statistics and health indicators? She demystified the whole gamut of camouflaging the debates around statistics, and she made it so palatable to the participants, so that it also evoked a very interesting debate. Yesterday, on day 3, we had Padma Bhate Devasthali's extremely empathetic presentation on gender-based violence and health systems response. She gave so many experiences of how when the survivor of violence approaches the health system, what kind of biases they face, what kinds of commissions and omissions take place, and what kind of new protocols, SOPs they are there. She shared her experiences of last 30 years of organization in Sehat and the Dilasa model, and she also showed a film on Dilasa, and she also the empathetic way of counseling that was shared. Dr. Asha Sheikh's session on response of healthcare system with regard to gender diversity and intersectional marginalities was extremely mind-blowing. She also deemed both of them, Akshay Sheikh and Padma Devasthali, they complemented each other by demystifying the laws. They explained the social determinants of gender-based violence against the sexual minorities and the transgender people, intersex people, prejudice and stigma against the gender minorities, and the response of the state and criminal justice system was dissected, and a lot of learnings came out. And she exhorted the participants to act against the violence and embrace gender diversity in a day-to-day life, not only in terms of platitude, but also wherever we are. We have to, in action, we have to prove that we are committed to gender diversity, whether you are in community or at a workplace or in the family. Their erudite and well-documented narratives were marked by such a deep empathy that they touched both the head and heart of the participants, and Q&A session followed following these lectures. They deepened the deliberations, and I think we have thoroughly enjoyed, we as organizers have thoroughly enjoyed the level of seriousness and proactive participation with the participants have done. Congratulations, dear participants. Thank you.
Thank you so much, ma'am. Now I would request Dr. Amar Jesani, independent researcher and teacher, Bioethics and Public Health, and editor of Indian Journal of Medical Ethics, to begin his session on the topic of gender, health, and human rights. Over to you, sir.
I hope you are able to see the presentation.
Yes, sir.
Okay, okay. It's moving, right?
Yeah.
These are the two major problems that I have to. Anyway, good evening to everybody, and thanks for inviting me here. Well, to be very frank, I was not very sure what I was going to talk about, so I had to really scratch my head because everybody who spoke earlier in last few days have covered a huge amount of ground. So I made some efforts to focus human rights while interpreting it from gender as well as ethics perspective. This is a journal we publish. I'm sure most of you know about it. And if you want to write something, please do go ahead and do it. This is a peer-reviewed and indexed journal, and it's open access. We don't charge from the authors either. So yeah, this is a kind of a platform where you can write on human rights, ethics, gender, and those kind of issues. Anyway, this is what I'm going to cover. I thought I'll try to cover it in three major issues. One is to look at human rights. The other is look at gender and gender and reproductive health related issues in the health and human rights. And the third is that can human rights provide a bridge between those who are fighting for right to health and those who are fighting for gender and reproductive rights. I thought of adding the last thing simply because I thought the movement in India is quite fragmented. You will find that there are organizations which are campaigning for universal access to healthcare services. Somebody is talking about universal health coverage. Others are talking about having a larger system, something like national health system. And the organizations spearheading those movements are not having, the representatives of the women's movement as well as transgender and LGBTQ movements. So you find the reproductive rights movement is working in its own way. The people who are fighting for the safe abortion in India, they are not found in the universal access movement. So what I thought that I will talk about first about healthcare and human rights and see that what kind of universal access movement that we can have and have some history as well as its philosophical foundation, and then go into the integration of gender and reproductive health consideration in the universal system. And then again come back to the strategic issue that how all of them can work together. There's one thing very clear, and why we have to talk about human rights in health is a inverse case law. Those who require medical care the most, they receive the least. So the people who need it, they don't get it. Those who have a lot of privileges to have it, they get too much of it. So you have on one hand oversupply, on the other hand no supply or very, very little supply. So this is the kind of system that we live in, because much of it is determined by the market. And the healthcare or medical care is looked at as a merit good. And as they say that meritocracy is ultimately to preserve the privileges of the people who are already having advantages. Those who are really critiquing this, they have different kind of philosophical sources, and I believe that all of them have something good to say, but each one is having certain limitations. We can talk about egalitarianism, where we're saying that, well, all those inequities should be reduced, but it still is a supply side issue, in saying that, well, we should have as little inequities as possible. Or you go to the sufficientism. This has said that, okay, everybody should have certain minimum available. Beyond that, well, they are at the mercy of the market. And so we talk about what minimum that can be provided. That's how you have different kind of standard. That minimum standard that you've set up for the poverty, minimum standard that you set up for, say, services which are openly available without any charge, like government services. So you find that it is a list one, that is enough. This is the only thing that we'll give. On the other end, you also have a movement which says that we should focus on those who are the worst off, prioritize those people who are getting the list. And that's from where, all these things combined, ultimately flow into the whole idea of universalism, saying that let us do something by which you can provide universal access to healthcare services, that everybody should be able to get services irrespective of their capacity to pay. That is removing the economic barriers. I think that has been the fundamental to much of the discussion in the universal care. Let us see how human rights and universal access system develop. Most of you know about the human rights, but I think given as a background materials, one document on the human rights, which starts from the Universal Declaration, where there are certain, rights enumerated. I am just giving few of them, which are connected to the determinants of health and directly connected to the healthcare services. So these are the ones, and you know about the 3 generations of the human rights. You know about social and political rights. They're saying that, well, certain kind of people should not be deprived of the services. That means they should not be stopped from accessing it. Now, that does not mean that the service will be available and accessible to them, but it is that they cannot, on social and political ground, be barred from it, So there are civil and political rights. It's like saying that abortion is criminal offense, and so the abortion is not available. But like India, you can definitely, legalize abortion without creating service for the abortion. So abortion is, you can have abortion, but there is no social and economic right to actually get it free of charge, and close to your place. So that's how civil and political rights, economic and social rights, cultural rights, and the specific rights of specific groups, all of them develop in 3 generations that you might have looked at from 1948 till now. There's a massive development of the rights, and there is a somehow widespread recognition of those rights. What is very important is that when we struggle for simple civil and economic rights, that okay, the abortion should be liberal, but that will remain incomplete right unless the socio-economic right to abortion is also provided. So this is a whole issue of it, they being universal, they being indivisible, and they'll be non-negotiable. I think this is the foundation of the human rights is a lot in the universalism of that kind. And the second part of right to health is a further development, saying that what are the different components. So it comes, basic understanding is that nobody can give you health. What society can give you is the right condition for being healthy. Now, whether you will remain healthy or not, that is a totally different issue. But is the condition available? A condition for the positive development of well-being and the health. If those conditions are available, then what you can say that the supply side issue, the provision side of issues are taken care of. And this is what the further Article 14's development is the right to highest attainable standard of care. which is about, which talks about that you should have enough services available. The first you create the services, and creation of services is not sufficient because just having service does not mean that people can access it. So you can have big hospitals which are controlled by corporate, but people cannot access them because they don't have funds. Or there are, institutions which discriminate people. They do not like certain kind of people going there. So it's another problem is making it accessible, right? So it's a geographical access, financial access, social access. Acceptability is also related to the culture as well as the ethical conduct of the services. And you know that quality. You can't have a second-grade services available to everybody, but it does not have enough quality in it. And that's how the cutting across all of them is non-discrimination. And unlike civil and political rights, which actually tries to say that state or there should not be any policy or social order which prevents people from their freedom of accessing what they want. That is what we call negative rights, where we say the state should refrain from restricting people, as compared to that social and economic rights are positive rights, where the state actually is required to intervene, either to regulate whatever is there, like say private sector, so that people are not faced with prices which they cannot afford, or or it has to create services on its own which can take care of people's needs. So it's a state's job is to respect, protect, and fulfill. All the three are the major works of the state. So this is human rights developed in the health has a long historical background of development of universal healthcare services in the early and later part of 20th century. As you know that the primary determinants of health most of them are socio-economic. That's how the Rudolf Virchow, you might have heard of him, was the social epidemiology that is the discipline that he founded in mid-19th century. And he said medicine is social science and politics is medicine on a grand scale. And that dictum was taken by heart by the developed countries because they had colonized most of the current low resource countries, and using those resources, they cleaned up the society. They provided nutrition, they provided sanitation, they provided safe water, and the infectious diseases were brought under control much before the drugs effective against infection diseases were discovered. So you'll find that the antibiotic and the medical intervention, which is considered to be very important now, was no longer it was nowhere at this level in the latter part of 19th century and early 20th century when those diseases were brought under the control. What happened in the latter part of the 19th century was the development of what is called scientific medicine, the germ theory, the asepsis, antisepsis. Hospitals as a place where people can go to be treated came up only in the latter part of 19th century. And you will be surprised that before that, people will not go to the hospital to get treated. They go to there to die. And most of them who go there are the poor people. Rich people will get medical care at home. Right? They will never go to the hospital. It's only in the latter part of the 19th century that hospitals develop, along with that nursing as a profession. All those things happens in the latter part of the 19th century and early 20th century. And you'll find that most of them were preoccupied by two things. One was that they saw that the market was not able to take medical care, health care to everybody. So they realized that there is a market failure. There is a Vibhuti, you have a hand up? Sorry. Anyway, so they thought that there was a market failure when you have a market-based healthcare services, where the consumer does not have much say in the medical transaction. Any one of you who has fallen sick and gone to the doctor will testify that it is very, very difficult to interrogate the doctor and ask right question. Most of the time, you will trust your doctor, although you may not trust the medical profession, but your doctor, you will find it is a good doctor. Okay, and that's how you'll find that there is no consumer sovereignty and consumers say there. You ultimately take what the doctor prescribes, and that's how the market failure is very, very common. And that's how healthcare services in the market system develops only in those areas that people have purchasing power. And the second the realization at that time was that there is a vicious circle. There is poverty, poverty creates more ill health. And when you fall sick and you have to pay for the private care, you become further, become more poor because your asset alienation takes place. And so further poverty is created. And that's, I think, a story of India also. We have anti-poverty program, and healthcare is one of the major contributing factor in creating more poor in India, right? So this vicious circle was recognized in the early part of 20th century. And that's how, with the massive, struggle of the trade unions and the working class in many, many places post Second World War, in the developed countries, the universal access system was established. And they say that, well, it's not only public health, which is a social good. The private, the medical care, which was considered to be private and merit good, is also a social good, because if you provide it, you create people, make people healthy. They provide you much better skilled labor power, and also it reduces poverty, or it prevents the creation of poverty. So it is very, very important. And I think they were able to do simply because during Second World War, the society created some kind of empathy with each other. People from the poor background went and fought at the front and died, So rich were somehow, indebted to them. And that's how you'll find that there was what was called the principle of solidarity, that the rich will pay more as compared to the poor, and it will create a cross subsidy in order to establish the universal access services. So this is how this was this was worked out. In next 20 to 30 years, they discovered that just having a formal equality, a formal universalism was not sufficient. I think the famous report that came out in early 1980s, I think in 1981, if I'm not mistaken, by a Black report it is called, which showed that the social determinants were such a bad thing that even when you have, openly available, freely available health services, you will find that the people who are coming from poor and marginalized communities, they are not able to use it properly. They also found that the system itself has a lot of biases, even the universal system. So gender-based biases, race-based biases, all of them started coming up. The biases against the working class, biases against the migrant, all of them started coming out. So 60s and 70s, when the gender movement, the women's movement became very powerful, that exposed the hollowness and problems of the universal access system. And so it came out that if you are building universal access system without looking at the inequities and the social determinant, you may not succeed. You may still have universal access system with a lot of inequities in it. So you have to see that your dominant strategy of establishing universal system is very sensitive to the issues related to the equity. And they are from the very beginning taken care of. And it must be very sensitive to the people who are the most marginalized in the society. And they may be marginalized because of their race, because of the caste, because of the gender, and not only women, but also all gender I'm talking about. And so that is a very important area that must be kept in mind. So it's from the beginning when we fight for such a system in India, then all of them will have to come together. Otherwise, you will create a system which will get discredited, or which may get defeated simply because there are a number of other people whose interests were not taken care of, and sufficient attention was not paid. Now, I had given some papers, background papers to you to read, and I think these 3 background papers, they are the one which bring out what I am just now arguing. This is one paper with Sophie et al. They are talking about the minding the gap in terms of financing of the universal healthcare services. So where gender issue must be taken care of, which is a very strong argument that is made here. It says that it has to be very sensitive to the equity issue. It has to ensure that there is a financial people who are having more capacity to pay, they are made to pay. They talk about the progressive taxation system. Current taxation system, as you know, is primarily based on indirect taxes, where the people pay huge amount of money. Only few percentage of the population pay the direct taxes, what we call income tax, and that is also a very small component of the total tax generated. Any universal access system that you find, you will find you'll see that the taxation system is different, more progressive. In the Western Europe and say Canada, people may even be giving away 50% of their salary for the social security. So it's very, very important. So it's and it is also very important how this money is used and why it should be prioritizing women and the children first. That is what is the argument. This is mainly focusing on providing equity to the women and the children. So it should be public finances. It should be resources from the progressive taxation. It must be able to regulate private sector and not just regulate in terms of control, but also price regulation. I think they have very strongly stressed on this, that any regulation of the private sector without regulating prices is not going to produce any kind. I mean, otherwise, it will be very bureaucratic regulation. Everybody has to register this, that, and all. And our inspector goes there, takes money, and disappear. Right? But price regulation, giving people right to make complaint and get redress mechanism, they are also very, very important. And it should be able to provide coverage to the different women, particularly those women who are not capable of purchasing the healthcare. And the social protection, when you start to build it, should go beyond women below poverty line. Today, what most of the protection that the government talks about is are the scheme which are centered on the people below poverty line. They say that no, that is not sufficient. You have to go beyond it. And one has to also look at this political and social determinants of health. That is education, water supply, nutrition. That is food. When we talk about nutrition, remember, it's not micronutrient and protein shake we are talking about. We are talking about getting basic, the balanced diet for the people to eat. And according to their cultural needs, it's not about being sattvic. It is about what people actually would like to have. And the high protein diet are normally, for the poor people is a non-vegetarian diet. The second paper that I had circulated, which complements what I had argued, I think it's a very important area, which is this is about transgender and those people who are not very comfortable with the gender assigned to them, and they would like to have a transition from it. And so this gender affirmative healthcare is very important. And what this paper provides you are some very strong philosophical and ethical arguments for it. It's like telling that maternal health should be a fundamental right. Abortion should be fundamental right. Now, maternal health is a normal physiological health issue. It's not something that is pathology, right? Abortion is not something pathology. It's about the need. It's about the social need of the women. Same way, we should not argue, and that is what many times argued, saying that, well, we should provide gender affirmation simply because it is kind of an illness, and then you have create various categories of illness because that they are not able to, they are not able to have some kind of a balance between various kind of stuff, and so they may be, provided support in the medical care system for the transition. No, all these natural rights issue are not sufficient. It is not something to be cured. It is not something where the illness is taken care of. It is a normal thing. If illness comes, even a mental health issue comes, that comes simply because of the discrimination they face in the society. It is the society which creates the illness in them. It is not that they are ill because their gender affirmation is different from what is assigned to them. And that is what it argues and says that it is neither a physical illness nor a mental problem. It is not a pathology. Abortion is not a pathology. Pregnancy is not a pathology. Childbirth is not a pathology. Yes, things can go wrong even in the normal physiology. When it goes wrong, yes, there may be illness, care should be required. But otherwise, it is not pathology, and yet it is the duty of the medical care system to provide it. That is the right that is to be created. And why healthcare system should be responding to that right? And he gives two major arguments. He says that it is because they have a right to act and live with integrity and to be recognized as a desired gender. And that right should make a duty of the medical system to help them out in doing it. That is what the medical system is about. They have a right to be authentic. They have the right to be true to themselves, And that is where philosophically and ethically, the justification for the intervention of the healthcare system for fulfilling the right of the transgender people comes here. So this is a very important issue that is raised in this paper. And I liked it. I said that, well, it is very important not just to talk about the larger universal system, but we have to also look at this, what is there within the system. Is system having biases? Yes. I'm sure that there are so many studies will show that when these people, those who are, want to change their gender, they go to the system, they find, problem because system is not responding. And this provides you very strong argument for the medical and other professionals in the healthcare services to respond to it. This is like doctors saying that we have a conscientious obligation to provide abortion. We all have heard about conscientious objection. Doctor says that I will not do it because my religion is does not allow me, or my ideology does not allow. But at the same time, the medical system has an obligation to provide the services, and doctors have to stand up and say that this is not the issue of objecting. This is the issue of using conscious in a positive way to provide it. The same is here in the gender affirmation. And these are my last slide, and that is my third paper is about Argentina. You might have felt surprised that why did I choose a paper from Argentina, because Argentina was when I was very young in 1970s and 80s. I had looked at it for massive human rights violation by the military dictatorship there. The missing young people. And the most prominent feature of Argentina that I remember in my early days was the demonstration and the movement of mothers who were looking for their children. That my son has disappeared. So being mother was considered to be so very, very important. And they overturned the system, the military system, and they built a democratic system. And since motherhood was highly glorified, they realized that although they got democratic rights, but they did not get the abortion rights. Immediately, the people who were from the conservative background, they stepped in. And they started using very secular argument. They will not say that no abortion because you are Christian. There's a no abortion because it's an issue of parental rights. It's an issue of fetal rights, It's about natural rights, Pregnancy, childbirth are natural processes. We cannot be disturbing it by doing abortion, right? And in US, they had the similar kind of problem. This was that fetal rights were asserted by the conservatives. And so they realized that perhaps human rights is not a right way of going about. Let us use something else. So they started talking about, instead of reproductive rights, they started talking about the social justice, reproductive justice. Right? And the author explains her own, ethnography, saying that how she changed the views, that in certain concrete contexts, she realized that there is a very close connection between fight for democracy and fight for abortion rights in Argentina. And these are all the arguments that she has, provided against those who are opposing abortion. They said that legal restrictions do not reduce the number of abortions. Abortion is fairly accessible to women who have money, even when you are, when it is illegal. Abortion is rarely prosecuted. And the effect of illegality and clandestinity is disproportionately affecting the young and poor women. That's how, the more of the complications related to pregnancy coming up and all. So decriminalizing abortion is a matter of social justice, equality, and protection of poorest and most vulnerable. And that is actually the goal of establishing democracy in Argentina. So it is some kind of a democracy's debt to the women who fought for the democracy to provide them the right to abortion. This is my last slide. Human rights had been a winning strategy for the democracy. And if you use both civil and political rights as well as social and economic rights, then it is a much bigger winning proposition. So for achieving progress on almost every front except the legalization of abortion in Argentina. Thus, it is a vital goal yet to be achieved under the rubric of human rights. That's how they thought that the women's movement, which is fighting for abortion, should remain in alliance with the larger movement for the democracy and equality. Rights focus allows activists to keep the pressure on the political leaders. They do not want reproductive rights to become bureaucratized, depoliticized, or medicalized. We saw earlier, isn't it, that reproductive rights and gender rights, particularly transgender rights also, included, they all are not to be medicalized, not to be pathologized. They are civil and political and economic rights. And so if our movement keeps the focus on the politicians, on the policies, then you are able to change it. There's one thing that I have found as a health activist in last 50 years is that many times people do not want to say anything about the health system because they say only doctor can say, health thing only doctor can understand. Very intimidating. But I don't know anything about, how. But if you look at any country where the universal access to healthcare system was built, you will find that it was built because of the movement of the non-health people. In UK, when it came, British Medical Association opposed it. In Canada, when it came, Canadian Medical Association opposed it. It went on strike twice. And that strike was overcome by the state because of the popular pressure. And they brought the universal system. So remember that, that's what it says, that don't medicalize healthcare rights. Healthcare rights is about organizing a system, which is society has to do it, within which technically a lot of work will be carried out by the professions like doctors and nurses and all. If you are able to bring them in your alliance, that is best. But even if they are not in alliance, you can still achieve it. Keep that in mind. So it's very, very important that you don't medicalize them. If you medicalize those stuff, then you will find that the doctors can be won over by the pharma companies, government, all kind of people, and then you will not win it. Importance to hold on to the language of human rights is very, very important. The language of rights could be applied to the realm of sexuality, bodies, gender, reproductive autonomy to bring about the changes in the policy. And the last thing is the aim to combine sexual rights and reproductive rights in same theoretical frame and as a unified social movement and a political alliance. Don't allow them to be fractured. Reproductive rights are not opposed to the LGBT rights. No, they have to be together because both of them are broader rights for both the gender rights of different kind of people there. In the US, it is happening. There is a lot of fracture, in various movements. To some extent, we also have silos here in India. And I think there is a task to overcome the silos so that there is a combined force to fight for this. I think I end here. And if there are any questions, then I can take them up. Let me stop sharing.
Thank you so much, sir. It was an insightful session. I would request Professor Patel to provide her remarks.
Yeah, thank you, Dr. Amar Jesani, for providing a very important historical analysis of how the universal versus targeted approach have a differential and results with the case studies of several countries. Privatization of insurance, how does it impact the poor people and deprives them of their rights? Third one is about the user fee from the patient, how it goes against the masses. I have problem with the question of regulation. I think regulation of prices, yes, but at the same time, we also need regulation of the healthcare services, such as medical termination of pregnancy. You yourself gave so many countries examples, and also PCPNDT Act, whether money or no money. I think there was a time where sex selection tests were available for just 80 rupees. In 150 rupees, in the till early 80s, we used to get abortion as well as sex selection. So I think we also need this kind of, which are extremely regressive or discriminatory. We need regulation. But the thing is that about vaccination, I wanted to, like, historically, we have been used as, at least in India, right from the colonial times till now, we were used to free vaccination by the state. For the first time, we encountered a reality where vaccination was extremely expensive during this health emergency. So what is your take on that? And what do you think about the public-private partnership that is happening in a big way, even at the subnational level? In several state governments have partnered with the private sector, especially the privatization of insurance. Even the state union government is also promoting that. Two things: vaccination and health insurance, privatization, public-private partnership.
Okay, I think the first thing was about the regulation. I think let me also take that up. So, I think what was said in that paper was that private sector needs to be regulated in many ways. It's not just about price, but normally what happens that in the regulation in India, the price regulation is always left out, and that's how it is. It is reasserted there. So there may be regulation about the quality of services. That is also very important. There'll be regulation about responding to the complaints of the patient. I think I mentioned about grievance redress and those mechanisms. I think they are very, very important. And of course, misuse of technology for things which are considered to be inimical to the social. That's, I think, sex determination is one such thing. But at the same time, I think there is also the whole issue of abortion. Safe abortion, sex selection. There have been a lot of tension between the two, and I think we have to overcome that tension. And that can be overcome by only coming together of the both sides of the activists and finding a right, what I would call language for the campaign. So sometimes what happens, the certain languages that are used in the campaign that puts off the another component of the same campaign. Both of them have the same objective to protect the right of women. They don't want any kind of violence. They don't want the sex ratio getting so imbalanced that it ultimately adversely affect all the women in the society. So I think that is what needs to be brought together. The second issue is about vaccination. You see, vaccination as compared to medical care is considered a part of for the public health. And public health is looked at as somehow a social good. What we call this is something where any intervention is not about the individual, but it is for the larger group. So vaccination, what it does is that if you vaccinate people, not only those who are vaccinated, they will benefit, but even other people. It creates herd immunity, in the entire community, and so entire community gets protected. And that's how vaccination is oftentimes not considered as a merit good, but as a public good, that the state should be doing it. Now, during the COVID time, government did talk about charging money, but ultimately ended up providing everybody free of charge. So they realized that would create a totally wrong, thing there. So that happened, and you'll find that they had to provide the vaccination to everybody there. But there are a lot of other issues related to the COVID vaccination, which are more complex, and you require a separate session on it. It's about how it was discovered, how the research was carried out, and whether we had enough data about its adverse impact, on the human health. So there are a lot of issues there, and there's people keep talking about it. And the last thing is about public-private partnership. Now, public-private partnership under in a broad market economy dominated by the private sector is normally in order to hijack the public services for the private profit. That is how it happens. The other way is that the government purchases services from the private sector. So the government announces insurance saying that any woman who wants to have a surgery will provide it this much of money. And they all go to the private sector and get it done. So, not only they take money from the government, but they can take additional money from the woman. This is how normally it happens. So it is more of for the benefit of the private. So that kind of public-private partnership is a problematic. But when you establish a universal care system like the NHS, National Health System of USA or a UK, it is not completely public system, but it's publicly financed. All general practitioners, 42% of all the medical doctors in the National Health Services are private practitioners. But they all are contracted inside the services. When you contract in, you have a complete control over them. Not only that, you can tell them that you cannot provide private service to anybody. I remember my first encounter with public system in the hospital setting was in Netherlands when I was, in late 1980s, early 1990s. I was visiting, and I was taken to several hospitals. And then I found that one company was having two hospitals. He said, this hospital is for the Social Security. And that hospital is private. The private sector is not abolished, you know. I said, why this too? He said, well, if my hospital is contracted in the services by the government, then I take only those patients who are coming from the government. I cannot take anybody else. And taking any other case is a conflict of interest, right? If you are running private, you just cater to the private. Otherwise, what happens is that if you are doing both, as it's happening today in India, then it is actually to get more benefit taken out of the public services for that. So public-private partnership of certain kind are, as they are happening today, they are detrimental. They are actually corporatizing the healthcare services more, and healthcare services are getting more concentrated in the hands of larger corporates. It's not about the larger corporates per se, but it is about the way they are structured. You know, the corporates are structured in such a manner that they have to work for the investors. Their main priority is investor. Investor wants certain money to come out, profit to come out. If it doesn't come out, they take money away from that. And there is a financial crisis. And that's how most of the corporate sector hospitals will put profit above everything else. And that's where the problem comes. This is how the entire market operates in the public-private partnership of that kind. Anyway, Roshni? Oh, there are also questions.
Yes. Good evening, all. Dr. Jesani, I have asked this question to you earlier too, but I'm coming back with more scholarship now. Not including HPV vaccine in the universal immunization program. Well, we had two imported vaccines that were made available, but on a paid basis, right? Now we have an Indian HPV vaccine that is there in the market, and it is not still available for free. It is a 2-dose vaccine, and each dose costs about 2,000 rupees. Yeah. Now, how many people in India will be able to afford this kind of charges for the vaccine to save their girl child? Now, it is not only about girl child, but it is also about protecting the boys. Penile cancer also has been associated with HPV. Now we have a death rate of about 70,000 people dying of cervical cancer, women dying of cervical cancer. Of course, it is not #1 cause of women's death in India anymore. Breast cancer is, but that does not mean that we do not think about that. Yes, we do understand there was one unethical study that was conducted, because of which this has been completely stalled. It is almost 12 years now, and we're still not even having a conversation about bringing the HPV vaccine into the this thing. Now, one of the explanations that is given is, one of the explanation that is given for not having an HPV vaccine. Imagine the entire world is having HPV vaccine in their UIP, right? And one of the explanation given is, oh, now we have screening. But recently, I read an article which systematically reviewed what is the scope of screening that has occurred in India, and it is about 1.2%. So how are we going to explain
Roshni,
this?
can I reply? Because otherwise we'll not have time for other questions.
Sure.
Because I think you were talking about screening. The point is that even if you provide HPV vaccine to women, there has to be a universal screening program in place, just like universal HPV vaccination program.
Yeah.
And I mean, as a scientist, because I know that you come from science background, that HPV vaccine will not provide you protection more than 70-75%. The rest will have to be looked up through the screening program, because they may develop, the HPV infection and subsequent carcinoma. The second part is that just numbers are not sufficient. What you require is what is the occurrence and prevalence of cervical cancer, and using a conservative approach in order to identify do early identification of the precancerous lesions and intervene, as compared to that, providing HPV, because you have to have some cost benefit analysis at the national level to be carried out. In order to have universal immunization of everybody or every young girl in this country, the amount of investment that you have to make every year, you have to look at that part, right? And even after doing that, you must have a good health system to do screening, and those who still develop carcinoma to provide intervention, right? Now, there was a excellent study done, and this was a massive debate on this subject because it became very controversial, when Sama came out with his report of deaths of girls and all. But there was a massive, serious discussion. Several major conferences took place in Delhi and other places on the subject. In Thailand, where universal access system was being built, they realized that they would not like to provide HPV vaccination, but they would like to have universal, universal screening. Why? One, as I told you, that it was more cost benefit because vaccine was too expensive at that time. Second was that when you do the screening, and if you want to do it universally, you cannot do without setting up a good healthcare center. So you have to ensure that your primary health center and sub-center are functional. That is one. It has laboratory. Cytological testing is to be done. So you have to really have a microscope and laboratory technician sitting there. And so also a doctor, a gynecologist, or a female doctor who can provide services to women, right? So they realized that in order to build a universal system which can reach out to everybody, not only to certain middle class, but everybody, then it is much better to put the entire money in building the system so that you are providing services to everybody. Every woman is able to get screening. And as you do it, and as you have more funding, you gradually introduce the vaccine into the universal system. And the last point I tell you that is that you will find in literature, it's not only HPV vaccine. There are vaccines for so many things there. You may find more than 200 vaccines in the market. Now you have to ask this question that why all these 200 are not part of the universal immunization program and why only certain are there. Now that depends upon the epidemiology. That is their occurrence, prevalence is so high, and what is the level of coverage of immunization that you require in order to create immunity to such an extent that you are able to really bring the disease under control. Those are the major issues, and you will find that there is not much work done on it. Yeah. So I'm not saying that you are wrong. What I'm saying is that there's a lot of homework to be done in order to actually argue that it should go in the universal immunization program and made available free of charge. That's a very, very, simply because Serum Institute is producing does not mean that we have to put it for the universal immunization program. I remember Dr. Badwe, when he was director of TMC. I think he's still there in other capacity, but he arguing in a meeting that we had organized as a debate on carcinoma cervix at KEM Hospital, that the requirement, the actual incidence of cervical cancer is going down. It's not going up because of the improved hygiene conditions and those kind of stuff. And I don't know. It is again less in certain communities where circumcision is male circumcision is practiced. So again, it has all those things. It requires some more work on it. So I would not hazard, jump and say that every vaccine that comes, we must have it in the system. How to have it, to what extent to have it, I think policy decision needs to be taken on that. Even universal system will not be able to sustain if you say that every new technology that comes should be there. One of the reasons why national health system of UK is falling apart is a patient's demand to have high technology that is used in America, introduced in UK. Now, UK spends 8 to 9% of the GDP on healthcare. America spends 20%. If UK is ready to spend 20%, then you can have the same technology brought there. India spends 1.3% of the GDP. If India wants to spend 20%, then all this technology you can put in there. So you will have to have some kind of a balancing out, that you don't deprive people, you give them alternative, which are at least effective, which may, to take care of their healthcare needs. And that's how the universal system will work.
Yeah. Okay, now Ms. Britika, can you unmute and ask your question?
Yes, ma'am. Thank you, sir, for your session. So my question to you is, the right to access to medical education, especially medical information, is a largely overlooked issue, especially considering the increasing rates of unwanted cesarean births. Jammu Kashmir is witnessing the highest rate probably in our country. So what kind of policy provisions can bring greater accountability to medical regulations in healthcare regarding this, and also bringing greater accountability for reproductive rights in India?
Well, the cesarean section is a massive issue. An urban area in localities where the middle class people go, the cesarean section rate goes even beyond 50%. But most of the data will show that that you don't require more than 15% of the women will not require cesarean section. They can deliver vaginally in a normal delivery. Now, this is the issue that requires a lot of education, not only of doctors, but also at the same time of the patient. Now, sometimes there is a lot of demand for cesarean section. The second part is the way the maternal services is organized in India. Normally, what happens that if I'm running a maternity center as a small hospital, and I live upstairs, on my hospital, and I try to take care, as a personal care. But at the same time, I would not like to be disturbed at night. What do? I do the planning. I say, why? If there is a normal delivery, if there are 10 bears, 10 women are in the in the various stages of delivery, and I am the only doctor, I'll find it extremely difficult to even get sleep. Now, unless you have a properly organized system where there are enough number of people who can substitute each other, which happens in a larger hospital. And there also, I think they require very strong commitment to the normal delivery. There are examples in the history, like the United Kingdom's national health system. I remember, influenced by one case, was Savage case, where Wendy Savage, who was a gynecologist, who was a feminist, who believed that cesarean sections were wrongly used on women. And so she took extra care to educate her on, women who were coming for the childbirth, and give them full, opportunity to deliver vaginally, the normal delivery. What happened to her? The other gynecologists had a charge against her, saying that she was providing substandard care to the patients in the National Health Service Hospital. And there was a Savage inquiry. There is a famous book, if you get hold of it, I think published sometime in mid-1980s. That was the title of the book, was Savage Inquiry. And you'll find in medical journals, long articles about it. And she was a good writer. She used to write in medical journal, British medical journal, Lancet and all. So I was fascinated by that woman's struggle, to do that. That's why the struggle is both in terms of providing education to the women who are seeking childbirth, but much more than that, there is a lot of education and struggle within the medical profession and healthcare services to change the system in such a manner that it really supports the normal delivery of the women. And well, as you know, I don't have to tell you that cesarean section is also connected to money that you make. If I do normal delivery, I may get few thousand rupees. If I do cesarean section, I get three times more. Now you have to take away this incentive of the money. If that is not taken away, then it will continue. And that's why, I mean, all of them have to go together. There is no one solution. All of this to be
The
done
same
together.
thing happened in the evaluation of Janani Suraksha Yojana, because when the government of India directed us RTGS to the nursing home, so many doctors were found to do unnecessarily cesarean section, because the money they would get would be 6,000, while in normal delivery it would be 2,000. I'm talking about the state-run program. Private sector would be doing even more.
Hysterectomies is another one. It's a big money spinner.
Yeah.
And the assisted reproduction is another money spinner. So you will find that the gynecologists are no longer doing as many abortions now.
No, they are not.
They because that is a very little money you get. But cesarean section, hysterectomy, assisted reproduction, because the market is going in that direction. That's where, and they also get better status within the profession and the society. Than being a small-time practitioner who is just doing a good normal delivery. We have to change all this perception as well as the way the services are organized and fight within the profession too.
So, Mr. Aquilin John, would you like to ask your question? Hello, are you there?
Yes.
Please unmute yourself.
So my question is, we know that class as a social determinant is something that keeps people from receiving the healthcare that they need. But I've also seen a reverse phenomenon that's happened, which is where because medical knowledge is considered esoteric knowledge and there is stigma related to asking questions where you have self-educated yourself, especially patients who are most easily dismissed by the healthcare system. And they're often accused of hypochondria or Googling their symptoms. And both of these terms have a reverse classist connotation where it is implied that because they have more resources and access to self-educate and self-advocate, this is a sign of modern mental illness, which is related to having wealth and education. This is also comparable to the victimization of LGBTQ community as being a modern or urban phenomenon, or the requirement of contraception as being a Western influenced phenomenon. So I was wondering if you have any thoughts on the use of class in a reversed manner to withhold healthcare rights.
Oh, yeah. This is a very thing happening, and I will find also in Indian Journal of Medical Ethics some articles published there. Doctors don't like patients who are well aware about their health situation, you know. And how does the patient become aware of it? You know, by either talking to some friend, or they Google it, you know, and try to learn from whatever database that is available, accessible to them, and understandable also. If it is too technical, you can't understand. But somebody who has written something in a simple language, you may be able to follow it. And that is now being done not only by the upper class people, but almost everybody. As far as doctors are concerned, they have not changed much. You know, they don't like too many questions. We did a study called obstetric care ethics. That was I think in the period 2009 to 12. You know, in 5 hospitals in Bombay and New Bombay, and we found some interesting thing. I think one thing was that in the public hospitals, largely people who are poor, they go, and the women in the obstetric ward are normally more subservient to the orders of the doctors. So the list question that is asked, those patients are considered to be much better than than patients who are asking questions. And what we try to follow was that a doctor who was, say, in the government system as an honorary, And the same doctor goes to a private system where he is charging money and having the same gynecological patient. And he found that there is a profound difference, The people who are poor, people who are getting free services in the government, they are hesitant to ask questions, even if they have done the Googling. But when you are paying them, oftentimes they do assert and talk and ask questions. And doctors find it extremely difficult. And they say that, what is this, And then when you can't handle something, then you say patient is delinquent, patient is hypochondriac, all kind of things will come up. What we call in medical jargon, the difficult patients, these are difficult patients. And then they try to create their own defense mechanism to put them off. So that, well, show them the place and ensure that they don't get too alienated and stop having your services. So you be very nice with them, listen sometimes if you are in the private service. In government service, you refuse to listen. So that, well, this is what I'm saying. Do it. I don't have time to interact. And normally they don't have time because there are too many patients to be taken care of. So this is what is there. And it does lead to some kind of victimization. Yeah. You can say that, well, that but it is not at the same magnitude as LGBTQ and some others, because there the prejudice is very strong, and which is very guttural prejudice as compared to prejudice against patients who ask questions. So, but definitely there is some amount of reservation of the medical professional to the patients who are creating this problem. Well, I don't know contraception as a Western influence. Well, I think at this juncture in India, when men and particularly women who have embraced contraception like anything, today we have much unmet need of contraception. Women do want it. Actually, they believe that in order to control their bodies, they need it. Men are most irresponsible today. The contraception is, that's how family planning as a target-oriented, high-powered program is no longer you see anywhere. There's hardly any kind of advertisement going on because survey after survey has shown that women want to control their fertility, and they want to do it at their terms and conditions. That's how also they despite being having more religion in the politics and all religion being against abortion still has not been touched, because if you do it, you will be alienating large number of women because they are using it. So there are certain things that I would say is nothing to do with Western influence, but you can say it has something to do with modernity. Yes, we are getting modernized. There is no doubt. I mean, within our own traditional framework, there is a modernity coming in us, and that modernity perhaps is making women to realize that they have a right to have a control over their fertility, and irrespective of her husband is cooperative or not, she does it, and that's what they are trying to do. So yes, I think there is a more consciousness there. They want to ask more questions to the doctor. To my understanding, if we encourage more and more people to ask questions to the doctor, it is good. You can say that this is the way you can push back and make doctors to listen. What is happening today is the doctors don't listen. They are the traditional way of doing medical examination, general examination. Talk to the patient, listen to the patient, take full history. That is not as much there around. They are more interested in laboratory findings, this, that, and all, which has a political economic connotation, as well as you're becoming more technician rather than being carer. Caring requires a lot of human interaction. That is reducing, and so if you demand more, it will increase the caring interaction. I think that way you can push back. So you can do the reversal of that, and that way you can bring about changes within. And you can argue. I mean, that's what all the transgender people's argument that was there in that paper from the Journal of Medical Ethics that why doctors should not look at LGBTQ people as a diseased people, but they should look at them as the people who need certain kind of services for their own dignity, for their own integrity, for their own authentication. And that is the job of the doctor to provide, right, as a part of the ethical duty. I think that way you can really push back everywhere by being more active in relationship to the health services. A docile patient will never be able to change the services. You require what we call patients' rights, not just in a very theoretical, abstract manner, but in actual practice, in day-to-day interaction with the doctor as well as the larger health services. Why not also with the hospital? Why only doctor? The doctor is only one small part of it. The bigger thing is is the giant behind the doctor. That is the hospital. I think we have to fight with them also.
Yeah. So, Dr. Jesani, can we ask you to answer second question by Dr. Aquilin John on chat box, because we are eating up the time of the next two speakers. So can we?
Well, the new guidelines which have come, I mean, they are called actually rules, and rules are legally enforceable. They are suspended completely at the moment, so it is not there. But even in the old Medical Council of India guidelines, as compared to the new one, National Medical Commission rules that has come, both of them talk about right to refuse the patient. The point is that I think National Medical Commission guidelines has framed it differently, and that's how several doctors, including myself, we had signed a letter to be sent to the National Medical Commission to change the wording. The issue is like this, that you can refuse the patient on genuine ground, ethically consistent ground. Like say, if you are doing say surgical abortion of 10 patients in next 1 hour, right? You cannot take the 11th patient and lower the quality. How much time a doctor should be spending in the consultation in the OPD, outpatient department? All those things are very, very important. That in order to keep the optimum level of care of the patient, there are certain things that needs to be done. And there, if there is more people, the more surgeries to be done, then you have to definitely stagger the surgery. That's one of the reasons in national health services of every country where universal access is there, the wait time for your surgery is quite a lot, and wait time creates a problem. People become frustrated, saying that I have to wait. You don't refuse, you stagger them, right? So the whole issue of refusal is a very problematic. That if it is refused simply because I don't like something, then it is not available. But see, there is a problem, major problem with the ethics guideline that you have not looked at, is that normally it will say that doctor will not discriminate on the basis of caste, gender, religion, ethnicity, and all kind of stuff. But it will not say that it will not discriminate on the basis of capacity to pay. How many patients are really refused by doctors every day because patient does not have money? Everywhere. This is my charge. If you have, you enter, otherwise you don't enter. Isn't it refusal? It's a big refusal there, right?
Yeah.
If you say that, well, LGBT people I will not give, you can still go to the court because there is a justiciable right saying that this kind of discrimination is not allowed, right? But there is no justiciable right to be on the discrimination if you face because you don't have money. So this is a certain problems, and the refusal, the way it is worded in NMC, needs to be changed. But at the moment, entire thing has gone under suspension. So the whole debate has suddenly been shut out. There was so much of things coming up because it was about generic medicine, writing brand name, and those kind of stuff. So everything is now gone out. Let's see what happens, whether the government does any consultation. Then we can take it up again, this one.
Yeah.
Yeah.
Okay. Yeah. Fiza.
Thank you so much, sir. So now moving forward, I would request Professor Uma Kulkarni, Professor, MBBS, DOMS, DNB, Yenepoya Medical College, Yenepoya, deemed to be University, Mangalore, to start with their session on gender and reproductive rights. Over to you, ma'am.
Thank you. I would first like to thank IMPRI and Yenepoya University for giving me this opportunity to speak on gender and reproductive rights. And a lot of this discussion was just now carried out during Dr. Amar Jesani's session, particularly with respect to maternal and reproductive rights, as well as right to abortion. And so we continue with the same session now. So we know that the reproductive rights are enshrined in the United Nations Human Rights Council, and it's also protected by the Constitution of India. And therefore, it becomes the obligation of the state to respect, protect, promote reproductive rights and fulfill them. A particular attention has to be paid to the vulnerable and marginalized groups. Women are already a vulnerable group, and within women with multiple vulnerabilities, I think multiple layers of vulnerabilities makes them really very, very vulnerable, and therefore they should be treated without any discrimination. So this is the roadmap in the next 25 to 30 minutes. And the sources of my presentation are the work done by SAMA, very good work done by SAMA, along with the National Human Rights Commission. Some of the inputs have also come from the narratives of some of the individuals I know personally who have experienced some of these issues. Some articles, news reports, and as a part of teaching the PG Diploma bioethics students. So that's a source of my knowledge about this. I don't have any field experience in this field. So this is a story I start with of Akkamma, Sakamma, which is called Sakamma actually. Sakamma in Kannada means enough. She is the 8th child of her parents. The last child is usually called Sakamma, after which they stop having kids. That was the belief. So she's from North Karnataka. She's now a housemaid in South Karnataka. She's working in Mangalore. She's a mother of 5 children. She has 4 boys and 1 girl. When she was pregnant for her 3rd child and she was staying in North Karnataka in a village, her husband doing some farming and she living with her mother-in-law, and she was about 7 or 8 months pregnant. She one evening had a quarrel with her mother-in-law, which turned out to be very, very serious, so much so that she was beaten by her husband. The husband was so angry that he asked her to leave the house, and without caring for the fact that she was 7 to 8 months pregnant, she walked to the village end with the 2 other children and stayed there at the river edge the whole night. And next morning, she walked to the other village where her brother used to stay. And she was welcomed by her brother and her sister-in-law, who was not too happy that she has come back home fighting with her in-laws, particularly abandoned by her husband. So she went there. She had her delivery done at the government hospital. 2 years later, her husband came back and called her home. And he said, mother-in-law, his mother, that is this Sakamma's mother-in-law, is not well. She needs to be taken care of. So please come back home. And when she did, she then raised her children, again had 2 more children. So she had 5 children in the house whom she had to support. She took care of her family, my husband, and today they have all shifted to South Karnataka in Mangalore. And now she's taking care of her own brother-in-law, who is fighting oral cancer. So this is a typical story of a woman who comes from a rural area where she gives birth to 5 children and she's not taken care of when she's pregnant. She's made to leave the house. And after all this is done, she's beaten up. She comes back home and still has 2 more children. So this is a typical history of a very commonly known Sakamma. One more story, again from North Karnataka, because I'm quite linked with the North Karnataka. I'm giving examples from there. She is from a middle class, upper caste. Sorry, the spelling of caste is wrong. She's educated and she's married to a lawyer. She has a first child who's a daughter, and the whole family is so upset. And the story is from the 1970s or 80s, where still there was a girl child was still wanted in even all the families. So she then had second, third, and fourth pregnancy. Each time she went to a family doctor who was known to them and a family friend, and who did the sex determination, which was again not legally done. And they found that all the 3 times it was again a female baby. So she underwent 3 abortions. When she underwent the third abortion, after the abortion was done, the doctor told her that probably it was a male baby and it was detected wrongly on the scan. So having said that, she had a fifth pregnancy, and the same doctor now refused to do any kind of a sex determination. Somewhere the guilt probably of conducting an abortion on a male child, probably. And then the fifth child was born, a baby girl, and this baby girl is born with physical and mental deformities. Today she is around 30 or 32 years old. She is not married. She's at home being taken care of her family. She spends most of her time playing with school children. Her mental age is still of a school child. I know the family very well, the family of Charitra. I feel very sad that such a thing had to happen, not just in rural areas, lower socioeconomic, poor, illiterate people, but even in a middle class and upper caste family. This is the third story I would like to start with. Could this be me? So she is a gynecologist. I'm talking about the story of a gynecologist. She once entered the hospital and suddenly she was called to conduct a delivery at the lift door. Why? Because a 38-year-old woman was rushed to the hospital in pain, labor pain, and she was fully dilated. She was gravid at 13. Her ANC report said she's gravid at 13 and has 12 living babies. She looked at the last ANC report and saw the hemoglobin level was 5, and she was using tablets, iron and whatever tablets required. And she was so angry and helplessly she screamed, "I'm going to cut both the two tubes for you this time and not allowing you to go for another pregnancy." This was out of frustration that the doctor screamed and said, "No, this is what I'm going to do for you." So these 3 stories, I feel, talk a lot about the reproductive health, the rights, abortion-related health and rights in India, and also talks about the health system, which is overburdened with these problems. So how have the reproductive rights evolved? So it started in International Conference on Human Rights in 1968 in first time, where the rights of couples were defined. Later on, they became more focused on women and started talking about the rights of women in terms of reproductive health as well as other general health. Later came the Vienna Declaration, and the program of action again defined more rights of women with respect to reproductive health and other health rights. Then came the first time where it was defined, the reproductive rights were defined in the ICPD in 94, and it was redefined, allowing more and more specific definitions to be allowed in the definition of reproductive rights, and that's how it is right now defined. The basic right of all couples and individuals to decide freely and responsibly the numbers, spacing, and timing of their children, and to have the information and means to do so. And also, this was the one which was added in the second definition, the right to attain the highest standard of sexual and reproductive health. It also incorporates the decision-making concerning reproduction, which should be free of discrimination, coercion, and violence, as expressed in the human rights document. So this speaks a lot, actually, of all the 3 cases that I just now narrated. I think you can already try to see that so many things are really not happening. Next came the Millennium Development Goals and the Sustainable Development Goals in 2015, which were more disease specific, and the limitation of these goals were that they ignored the social determinants of health and did not consider the diversity of women, particularly the multi-layered vulnerability of women, which we talk about. The Sustainable Development Goals, which came in 2015, also spoke about more target-specific approach. And many of the targets, as we can see here, directly or indirectly give an indication about the reproductive rights of women and other individuals. So let's look at the rights of Indian citizen linked to the reproductive rights. So we have so many rights, and I have picked up those which are connected with the reproductive rights, and one of them is the most important one, is the right to health. And we know that for right to health to be realized, we need availability, accessibility, accessibility, acceptability, and quality. These are the 3A and Q formula that we often talk about in the community medicine field. So in terms of reproductive health, essential health would also mean, essential medicines would also mean contraceptive methods, methods for abortion, medicines for abortion, and those for the post-abortion care, and drugs for the prevention of STIs, because we cannot separate sexually transmitted disease and prevention of HIV, AIDS from reproductive health, because there's a lot of overlap there. It also means that the personal health data of these patients should be kept private and confidential. So that's right to health. It also speaks about right to health, life and liberty, and the right to life is of the child, the to be born child, and therefore the care of the mother during the hospitalization, during antenatal care, postpartum care is very, very essential, and is reflects the overall health status in India. The aim of most of these sustainable goals and other goals is to reduce the infant mortality rate and the maternal mortality rate. Otherwise, it would be considered as violations to the right of life of mothers and their children. And therefore, we need to have a robust mechanism to identify the weak points in the system. You can't have one system which will work for everyone. So we need to find out. Next is non-discrimination and equality. And we know that social discrimination is rampant throughout India based on race. Just now we spoke about, Amar sir was talking about discrimination in so many different ways in which social discrimination can occur. Doctors can say, I'll treat all of them equally, but not when it comes to the paying capacity. So there is social discrimination, and definitely that leads to a poor access to healthcare facilities. We have seen many examples in which they are not able to access health, and more so the women with disability, sex workers, and sexual minorities who face more direct as well as indirect discrimination in the healthcare system. The healthcare system is not the only one which differentiates based on the person's gender and unequal, whether we want to consider them equal or unequal. It is inbuilt in the family system. So if I go back to my home and try to see who is the person who eats last at home, it is always the woman in the house. Even if the food is adequate, the table is full, it's the woman who sits last and serves everyone and is the final person who eats food. This has been a tradition. It's an accepted tradition. And I see in my OPD also had an example during the COVID time when a patient came with cataract, and she was because of COVID, she went back and she got her surgery done at a later stage during the lockdown, because while taking care of her husband, instead of sugar, she put some salt in his coffee. It is then that the husband realized that she really has a visual problem. Not until then. So only when he realized she has a problem, they came to the hospital, and not when she was actually suffering from the blindness. Same happens in any healthcare for a woman, and there are discrepancies in the gender. Next is right to education and information. Every individual, right from adolescence, so we need not consider only the adults or married women to know about the reproductive health and their rights, and the information regarding how to take care of themselves, but it is also the adolescents who need to be included, because even if we know that marriage can occur only after the age of 18 years, we know that sexual activity occurs much before that. And therefore, all these issues related to reproductive health, including family planning, use of contraceptives, prevention and treatment of sexually transmitted infections, reproductive morbidities, risks of pregnancy, conception, and practicing safe sex, all these have equal importance, and every individual has a right to this information and education, particularly the adolescents and younger ones. Next is the right to enjoy benefits of scientific progress. And one quick example that I would like to think at this time is there was a drug called zidovudine, which was found to be very effective in reducing the parent-to-child transmission of HIV/AIDS, which had to be administered during pregnancy. The trial zidovudine, the trial was conducted in the lower middle-income countries. And once the drug was found to be very effective and became the standard of care, it was available everywhere else, including India, but in India, it was at an unaffordable rate. So people who really required it could not afford it, and therefore they could not enjoy the benefits of the scientific progress, the research which was actually done on the lower middle income countries. So that right needs to be realized. The next one is right to privacy and marriage and family life. We know that reproductive choices cannot be only be done by the males. They have to be balanced, and both the man and the woman have to decide about procreation and abstaining from procreating. So it becomes a woman's right also. So there should be no restriction on that. But we know that there are multiple social, economic factors that determine whether the woman is able to voice her opinion, voice her desires and her needs about reproductive health and having a baby or not, having going for an abortion or not, how many pregnancies, etc. It's usually determined by the family, husband, mother-in-law, father-in-law, and who all. So in India, we have something called the Maternity Benefit Act, which was amended in 2017. And it caters to all the mothers who have given birth to children. And they give maternity benefit in the form of an earned leave, which has been increased from 17 to almost 26 weeks now, and which is very good. But the fact that most of them are not working in organized sectors, they are not able to take care of these, benefit of this scheme, because they work in non-organized sectors where this may not be applicable at all. And who's going to pay them where they are working? So that's a major issue with even schemes which are available, but many of the women are not able to take care of them. One good thing about this picture is we are seeing children are talking about prohibition of child marriage. This itself helps, because many child brides do not have the negotiating power in sexual and reproductive matters. So when they are married to an older man, they become vulnerable to violence and are more likely to have children at a very early age and more frequently. And they are also at a greater risk of maternal mortality and morbidity. And therefore, I think this is a very good thing that child marriages are prohibited, and in a way supplement the maternal benefits scheme and reproductive rights and safety of the mother. We have just now spoken about abortion, right to abortion. And when I asked one of the gynecologists, do you take consent of the husband while conducting a sterilization on the wife, and or conducting an abortion on the wife? They said it's legally not required, but for our safety, we do it. So practices are different at the ground level. What is followed by the doctors is quite different, because there's a worry about what will the family say, or when they come to know about sterilization, which the woman has agreed to, but the family may not have. And therefore, it can lead to repercussions and violence against the woman. At the same time, mob can actually enter the hospital. Nowadays, doctors are very afraid of being beaten by patients and patient parties. And therefore, in this communication, to be on the safer side, that's what they say. And they take the consent of both the wife as well as the husband, although it is not really required. So are we really respecting the rights of the woman here, or we are resting all the decisions with the husband and the family? That's a big question to ask. So we know that women come from different backgrounds, religious minorities, disabilities, women from indigenous tribes or sexual orientations, poor, illiterate, and they come from different backgrounds. So what may be true for me, or what may be a problem for me as a professor in a medical college, would be completely different from from a woman who comes to my house to help me with my household chores. Her problems are completely different. There cannot be one solution which will take care of all the different women in the society, and therefore a lot of individualization is required. Policies help to a great extent, but it is at the level of the doctor and the patient where this needs to be personalized, and individual factors need to be considered. So I see all the challenges in the field of medical problems and socio-cultural problems, and the problems associated with health system or the policies. If you can see this picture carefully, there's one bed and there's two mothers who have given birth to small children here, and the bed is being shared. This is a picture at Chandigarh Government Hospital where two pregnant women share one bed. It was reported in many places, including Hindustan Times. So what does that reflect? It reflects that there's an overburden on the public health systems. They're not able to take care of the demand that is there. The infrastructure is poor, the number of doctors available are poor, there are no facilities, no modern facilities, and the patients also cannot afford, say, they end up. There are other pictures I have seen where there's one patient below the bed and one patient above the bed also. So, but in different context. And here it's a maternity ward. Most of them are also daily wages. The women are working in earn small wages per day. And therefore, when they come to the hospital, their earnings also come down, and therefore they suffer a lot. So they cannot afford. However, it is seen that more than 2/3 they end up paying out of pocket. It is not supported by the GDP. Just now we spoke when Dr. Amar Jesani was speaking that only 1.2 or 1.3% of the GDP expenditure is on health. So how is the government able to support health care when it is required in such a huge amount? So many number of deliveries to be conducted in the public health system. Therefore, there is a need to rely on the private sector. But when we also spoke about this, that in the private hospitals, the increase in the number of cesarean sections we are seeing every day that the number of cesarean sections as per this tally is going on increasing. And what is the reason for this alarming increase in the number of cesarean sections? Is it that private sector is less regulated or non-regulated when it comes to the surgeries and all that? Or is it profit driven and therefore more and more cases done and more profit done? And does this also not increase the inequality which is present in the healthcare system? So that again is a big question. The question is, even if facilities are available and infrastructure, doctors, everything is available in a private sector, will a poor, lower socioeconomic person or a woman be able to access these facilities? That's the question. There are many schemes in India which are meant for the betterment of the women, and also includes deliveries, including natural as well as cesarean sections. And that is the RSBY, which we all are very familiar with. And 5 people in the family can access it. So the woman can access it multiple times. The problem here is that the amount of money which is given to the private sector is around 4,500 for a cesarean section. So will the hospital really be able to support women when they are paying only 4,500 rupees? So whatever excess amount is there, which the hospital has to bear, are given in the form of prescriptions to the patients for medicines, consumables, etc. And the patient has to again buy and pay out of the pocket. So the whole idea of these is that poor patients can get free treatment, but that cannot be realized when they come to the private sector. Even if the scheme is available there, even if they are beneficiaries of the scheme, they end up paying for hospitalization and other schemes. So this has been reported by many of the media, and it says that some unscrupulous doctors, this is exactly the script that is given in the news. Unscrupulous doctors and private clinics are engaged in blatant practices by frightening poor and illiterate women from marginalized communities into surgery. And one such surgery is the hysterectomy. I think many of us know how mass hysterectomy campaigns were conducted in order to make a quick money, and most of these women come from the marginalized sectors, poor people, illiterate people, and they become the targets. And this is all for probably the profit that they look for. That's about the health system. Now coming to the medical conditions of the women. These are the women of India who are all either pregnant or have just given birth to a baby. So you can see the health status. Most of them start thin. They remain thin throughout without much gain in weight. What was the weight at the beginning of pregnancy? 34, 35, 40 kgs. And at the end of pregnancy, 42, 43 kg. The weight gain is less. Anemia is there. They don't have facilities to go to the hospital. We know the famous story of Manji. And they are carried on stretchers or these beds to the hospital. They work till the last moment, or they carry heavy weights. They are not able to take care of themselves. At workplace, they have to take shelter on roadsides. And these are many issues that determine the maternal health. And therefore, what is required is good ANC, which is probably lacking in many sectors. There are interstate differences and inequalities with respect to antenatal care, emergency obstetric care. If there is any complication, for example, postpartum hemorrhage at a center which does not have all the facilities, from the time this is detected to the time the patient actually reaches the hospital, many lives are lost because no ambulances are available, no, the roads are bad, the family is not able to support a taxi or any such facility with which they can take them there. And on the way, many lives are really lost. There is a lack of skilled care during childbirth to manage complications. They may be able to take care of normal deliveries which do not end in major complications. But when a complication occurs, they are not able to take care, and referral services are very poor. They need to travel great distances, inadequate equipment, shortage of drugs and blood banks. There are stories about lack of blood storage facilities in the centers, because of which they have to travel long distances from one hospital to other hospital, during which critical time is lost. There are lack of postnatal services, infections, postpartum hemorrhage, depression, we are talking about yesterday. All these services are not available to the mother when it is required, particularly when we are talking about the rural areas. There are lack of safe abortion practices, which can also contribute to maternal mortality rate. And also, to top it all, there's a lack of accountability for the emergency and essential services. So this is a real story of rural India, where all these facilities are really lacking, although we talk about big goals throughout the universe. There are many schemes in India, a list of them. Each one is trying to give a continuum of care, incentives, free services, even transportation services. Everything is given, but still it is not reaching everyone in the community, and therefore we still have a problem, because 90% of the working women in this country end up having little or no access to such entitlements, which is a very sad story. Even if there is a facility available, it is not reaching the people who need it. Maternal benefits are restricted only to first pregnancy. What happens to the second child? It's not applicable to women in the informal sector. So what do they do, and where do they go? We have the MTP Act and abortion right. We just now discussed, so I'll just rush through this slide. And access to abortion care and services, because this is a critical public health issue across India. And we see that there's an article which says that 5 out of 6 abortions are not legal. That means only 1 out of the 6 abortions is actually legally registered abortion. About 5,000 abortion-related deaths occur every year in India, and unsafe abortions contribute to 9 to 13% of the maternal mortality rate. These are huge numbers. I think this is a big burden that needs to be tackled slowly. And on the other hand, we also have issues of autonomy and informed consent in the context of contraception. Many women do not know about the contraceptive methods. All they know is tubectomy. All they know is sometimes about the oral contraceptive pills and condoms, but they are not educated well about the use of condoms, that they can not only prevent pregnancies, but also sexually transmitted diseases. And overall education, comprehensive education is still lacking. Either they don't have the information, or sometimes they don't give consent. So there is coercive application of contraceptive methods, and which violates the rights. There are examples where contraceptive devices are forcibly placed immediately after delivery without informing them. So this is a study in Madhya Pradesh. It's a qualitative study on sterilization services, which says that most of the care in sterilization services was found to be substandard, and they were not following the guidelines, because of which we saw incidents like the Chhattisgarh sterilization camp tragedy, which we all know about. About 85 women underwent sterilization in a camp, and 13 women died of after the surgery because of poor hygienic sterilization methods, and they ended up in infection and sepsis. So this is really an alarming number. There are other instances also. There's one case in Telangana where 4 women died post-surgery because of the complications, and they thought it was acute gastroenteritis. And how this occurred, why this occurred, this was being assessed and later investigated. A 5 lakh amount and 2-bedroom house was given to the families of the deceased, and the surviving children of the 2 women were given residential schools admission. So this is the redressal that was done. So many of the guidelines are failing, and it's reported again, time and again, that Nasbandi, you can see the board here. It says incentives for sterilization, and many women actually might go for the amount of money that they gave by undergoing this procedure. And I'm just going quickly now. I finished by 30 minutes. So there are instances of denial of sterilization. I was first time I was actually reading through an article when I came across this. I was always thinking that it's always the forcible sterilization that is a bigger problem. But there are studies which mention about primitive tribal groups which are being discriminated and not provided the sterilization that they are asking for. So this is a very paradoxical thing that I came across while reading for this session, that sometimes sterilization services which they're asking for are being denied by the health services. This was the postpartum IUCD 2020 program, where insertion takes place many times without the consent, because they have been instructed to conduct postpartum intrauterine contraceptive device. The copper T is implanted on day 3 or week 1 or 1 month. They have timelines, so they have targets, and therefore they have to do it. And so many times they occur without consent, appropriate consent. The signatures are there, but appropriate consent is not available. So this is about the right to information, which information has to be there. You require accessibility and what do you say? I forgot. I missed that term. Accessibility, acceptability, and complete information. And many studies say that many people are not aware of how they have to take care of their reproductive health, including prevention of HIV and AIDS and sexually transmitted diseases. So the UNICEF report says that only 36% of adolescent males and 20% females have a comprehensive knowledge about HIV. So we often separate family planning program from prevention of sexually transmitted diseases. So where the two can be combined, and a more comprehensive education about prevention of pregnancy if they wish to, and also prevention of sexually transmitted diseases should both be taught to them. So these are the NICO related issues. There are concerns about this also because the government is not able to fund as it had promised before, and there are delay in release of payments, and therefore there is a possible increase in HIV infection rates, but it's not very sure that it's because of the lack of fund or it's actually reducing. And many people have gone back to the sex work and are following risky behaviors. So the last one about parent to child transmission, which we spoke about, the zidovudine drug, only 38% of the pregnant women living with HIV have received the prevention of mother to child transmission treatment, according to this publication. This is my last slide, and it also talks about egg donation, and there are reports where they say that for egg donation for the purpose of infertility treatment, they are offered somewhere around 20 to 25,000 rupees. And for women and girls from poor socioeconomic backgrounds, they consider them as a very big incentive and come forward. It carries a lot of social stigma, but the monies that attracts them, they undergo invasive procedures without really understanding the risks and benefits out of it. And there are reports where there has been morbidity and even mortality following these egg donation processes. There's a lack of regulatory mechanism for this, and they find these women from the lower socioeconomic group as a very cheap and affordable reproductive resource for reproductive services, and they're very easily available. The other aspect is commercial surrogacy. I think this itself is a big topic, and I'm just summarizing in 3 lines. It becomes a livelihood for the women, and therefore they do it rather than truly an altruistic way. Now there's a recent growth in the ART industry, and we see a lot of regulations coming up now. It's not very well regulated, and there's no national registry for it, so we do not know how many people are actually going through that. So we, this session, tried to summarize the evolution of reproductive rights. We tried to see how these rights are linked, our rights are linked to the reproductive rights. We saw how gender discrimination and inequalities exist with respect to reproductive rights. We also saw the challenges in terms of medical conditions of the patient, of the women, the social structures, socioeconomic structures, and the health systems. They have their inbuilt challenges which need to be addressed. So finally, recommendations would be you cannot have one solution. We need to go by case and case based. I leave it open for everyone to discuss. With that, I conclude. Thank you all.
Thank you so much, ma'am. I would request Vibhuti ma'am to provide her remarks.
Yeah. Thank you, Professor Uma Kulkarni, for such an exhaustive presentation, which has taken touch upon all the problems of women, whether it is a question of pronatalist policy or antinatalist policy, population control policy, reproductive health issues, how the healthcare system responds to that, and generally the biases that you see that also result in neglect and a lot of miseries for women. And I think you also broached upon the question of some of the minorities, such as primitive tribes. Like there are women who have complained 16 pregnancies, first child being born at the age of 12, and she's 36-year-old, and she is completely famished. And she says, I have no, my income can't feed so many children, and still they would not do this thing. So I think the insensitivity of the system and treating women either as a machine, baby machine, or women as a male child producing machine, or also women forcibly controlling the population. Just you want to meet the target of population stabilization. Main thing is the objectification of women, violation of dignity and bodily integrity of a woman, which you have brought out so succinctly. So I think it is a very, very important dimension that has come up in your lecture. And thank you very much. I don't have anything to add. You have covered everything. Yeah, correct.
Thank you so
much.
Right
from international covenants to the national this thing, and also all the critique of the flagship programs of the government. Yeah, please, the floor is open.
Thank you, ma'am.
Please unmute yourself and ask questions.
Roshni Babuji, you can unmute yourself and ask your question.
Thank you so much, Fiza. Dr. Uma, that was a wonderful, and thank you so much for doing that for us. I completely agree with Dr. Patel when she says that, you have covered so much, there's nothing else to add. But you must be aware that my topic for my dissertation is the Sex Selection and PCPNDT Act, and what do the gynecologists think about it, the implementation of the act. So, implementation is a challenge that is a given in a country like India because of the population, because of the health system challenges that we have, etc. But one of the crucial thing that came up in my study is gynecologists think that sex selection, abortion, is a women's problem. And for me, there is a lot of problem. It is a very, very wrong for us to think that it is women's problem, because the solutions they offered is educate women, make them financially independent, all those things. We know that it is not a women's problem, it is a societal problem. We know that it is a socio-cultural problem rather than a biomedical or a public health problem kind of thing. So what is happening here is the solutions or the strategies that are used are from the biomedical perspective and the public health perspective, not from a social, cultural, or economic perspective. So there is a study that is done in Rajasthan where they say that the conflicting message that abortion and sex selection. Sex selection is, declared as illegal, rightfully so. But women tend to think that abortion is also illegal because sex selection follows abortions. So, there is conflicting messaging that is happening. I can quote another, example. Our national family planning message shows mother, father, son, daughter. So that is the picture of complete family that we are giving. So how do you expect the people to understand that two daughters is okay?
Yeah.
There is a lot of conflicting message that is happening. Another thing that is that I saw during my dissertation is there is a global study that is conducted to see if sexual and reproductive rights has been taught in medical schools. And South Asian countries come at the lowest. One is they're not being taught. Therefore, gynecologists, doctors who tend to women, they are not aware of their sexual and reproductive rights. And thirdly, they also saw that there was no intent, because they say that, our college may not approve this because it is a political issue. So these are the problems. This issue needs to be targeted very strategically rather than looking at it as only a public health problem kind of thing. That is something that I wanted to share.
Yeah.
Yeah.
Yes.
Thank you for that. Yeah.
I think you have answered your question.
Mhm.
Can we ask Amruta Girish to ask a question?
Ma'am, I can state the question, given that we are already exceeding the time limit.
Yeah.
So
yeah,
the
fine.
question is, what is your thought on medical leaves from employers for women during menstrual periods? It is still quite startling how physical pain and emotional symptoms experienced by some women is trivialized. Do you think adequate pain medication and management products exist for women in terms of menstruation/menopause?
I think we all as women have gone through this, and we have some of us have had very mild symptoms, some of us have had very severe symptoms. And what is most useful at that point of time? I think leaves are not available, and I don't think there are leaves which are given, at least in the employment sector like us, where we are doctors and we are seeing other people who are employed. There are no leaves for menstrual cycles, because I don't think it will work out for them also. But what should improve is the healthcare during that time, where they are informed about what are the possible medicines they can use, and how they can take care of themselves, and how they can improve their general health so that they can withstand that pain. Because if you're already weak and you have pain, you are in a position to feel the same pain more severely. So if you can improve your health and overall health, physical as well as mental health, you'll be able to face the same much better. And having said that, we have almost 2 CLs, 2 casual leaves or 2 leaves. Even the woman who comes to my house takes all Sundays and she says, I'll take 2 leaves in the month, which is acceptable. But if those 2 leaves go on her menstrual days when she's lying down in the house, she'll not have leaves when her family needs it, or when a child requires it, or there's a parent-teacher meet in the school when she requires it. So I think it's not feasible for the employer as well as for the employee to have leaves for it. I would like Dr. Vibhuti ma'am to speak about it more.
Globally, it's a very controversial issue. I think some of the progressive managements and the corporate world, they have legalized menstrual leave. Some of the nations have done it. I think Australia, Philippines, the bills were, private members' bills were presented. European Union, where 40% seats are reserved in the European Parliament for women, they have brought this subject. So it is really a hotly debated issue. But the main thing is that whether it should be compulsory by the statute, which is legally bound, binding to a whole nation, or you keep it voluntary on demand by women as a backup service. So here lies the final differences in the approach. Yeah. Thank you. Thank you.
Thank you so much, ma'am.
Thank you.
Now, moving forward to the last expert of this course, I would request Professor Vina Vaswani, Director, Center for Ethics, Professor, Department of Forensic Medicine and Toxicology, Yenepoya, deemed to be University, Mangalore, to start with her session on gender justice in forensic medicine. Over to you, ma'am.
Dr. Vina Vaswani is the one who conceptualized the course, and we started it last year. Last year also, there was an excellent response, more so in terms of number, but quality of discussions were equally powerful and useful for the insights and perspective. Yeah, thank you.
Thank you very much, ma'am. That's been a learning for us. Actually, I believe that we teach best what we need to learn. So in the process of teaching and learning, we learn equally from the participants, from everybody, from the organizers. And so it's been like a perfume that it just spreads around. So I'd like to, I'm one of the lifelong learners who will continue to focus on doing better. Talking of gender justice in forensic medicine, I'm quite sensitive to the fact that when I entered forensic, there was a lot of insensitivity to the presence of females in the field. So first thing I was asked, why did you take forensic? Do you think it's like making rotis? Why didn't you take gynecology? And things like that. So I was so shocked that somebody would ask me this question, because I thought a professional behavior would not make a difference on gender, but I was quite wrong. And people just looked at me and said, I may not be fit to do it, because forensic is not it's totally a different ballgame meant only for men. So when I used to approach them and talk to them, try to talk to them, even in conferences, I used to think that they would stop talking and wait till I moved away so that they would have their conversation. So the otherification wasn't new to me, but at the same time, I also got used to the fact it gave me a lot of time to introspect. So in this presentation, we'll explore the importance of justice in forensic medicine, and especially what are the challenges and how we can create a more inclusive system for survivors of gender-based violence. I also take into consideration medical legal cases when you do examination and how we need to change in our approach, keep a change. And forensic medicine is a critical component of justice. We can't ignore the fact that we go to court to give evidence. So we should always be in the process of questioning ourselves. Where are our biases? What are our biases? And is it our bias that we are taking to court, or is it the scientific evidence? And are we confident in saying that it's inconclusive? I do not have much information on it, or I'd like to just go by everybody does this, so I would also like to do this. Because we should be very sensitive to the fact that forensic is not a science of exactitude. Forensic science, where you measure things, is different from forensic medicine, where you interpret things. So it's important to understand the role of sex and also differences and challenges that arise in promoting justice in this field. So I start with talking about the most two common examples where we come across the gender. That's in relation to sexual assault and in death investigations. So especially in the sexual assault cases, we are very, very focused on findings and the proof. Whereas there can be no findings, but yet it has been committed. You need to just explore in depth the history to understand what has happened. But we go by, in fact, our textbooks literally like a clarion call. If you don't find a motile spermatozoa, then it is not rape. Whoever said that? What science was that? It was totally humbuggery. But we believed that. And the textbooks were quoted. And the cases were thrown out of window that this is not rape. So forensic examination of a victim, especially of sexual assault, involves gathering physical evidence and medical information in a sensitive manner. The examination should cater to the specific needs of the victim, including contraceptive advice, irrespective of gender, sexual orientation, or identity. But from the time I started, this particular domain requires more commitment from forensic people. The very first conference, I was giving a guest lecture, and one of the senior most colleagues was telling, if a girl complains about rape, don't believe her. And I was shell-shocked. Why don't you believe her? No, because people will always make allegations. I said, where is your data? Is there a data? Don't question me. I have 30 years of experience. I know. But this is what leads us to our path of injustice. Nobody can know. Nobody can know. So we need to be humble enough to say, let us listen, give a patient ear, because the person before me is like me, a human person. Male, female, intersex, transgender, doesn't matter. But there's a person who's wronged. If I don't even listen, if I'm not open to listening, what kind of a justice am I doing? I sit with an opinion, oh, she must be faking. So everybody thinks everybody's faking. So then nobody's telling the truth. So no cases will stand the scrutiny in court, because we don't take history properly. We don't look at body language, the signs of distress. That is why we should be very focused. Secondly, autopsy and death investigation. Especially the more we do the death investigation, the more we try to look at the autopsy. And if you go with the preformed bias, it has happened at times when the genital wart has been confused to be a wart due to sexual disease.
Correct.
And in unmarried girls, in especially religious sisters, it has caused a great havoc. And you should believe that here the lie is traveling around the world because the newspapers make it a sensation, a sleaze, when nobody even asked what has happened.
Correct.
So efforts must be made to bring about the gender equality in death investigations. And role of gender justice in forensic. Gender justice ensures that all individuals are treated equally with respect, regardless of their gender, identity, gender expression. But this again doesn't happen. Because why? We make our own preformed impression. If it's a transgender person, we don't waste more time. We think that she was soliciting sex, she got less money, so she's asking for it. But who are we to make these judgments? On what information are we making a judgment? This kind of bias in our behavior will help in hijacking of justice. So in forensics, and ensuring gender justice involves recognizing unique needs of the challenges faced with people of different gender and gender identities. And we work in like a watertight compartment. So we look at two sexualities, male, female, and rest of them are ambiguous. And we don't even waste more time on it because we think we want to know what is your gender. We want to do chromosomal, but that is not the reason why the person has come. What are the needs why the person has come to you can be totally different from your academic interest in finding out. So now imagine you're a doctor in a rural center. You're the only doctor. A 45-year-old lady comes to you in your OPD with inability to breathe and giddiness. On examination, there is a black eye, there's conjunctival congestion, and we have a tram-like appearance, tram track appearance, we say, when somebody is hit with a huge rod. So the two parallel reddish streaks across the skin. So that is seen on the back. On probing regarding marital history, she agrees that she is beaten by her husband, not once, repeatedly, and she's sexually abused by his brother. So what do you do? So I won't wait here because I'm late, but I'm going to tell you what I would do, what anybody else does. Many people think, how does it concern us? If you make a police complaint, police will take her and go. Is that what we want? And secondly, the husband will thrash her more. We don't have a system where safely, securely, she can be taken care of. till such time that she needs care, and then the medical legal process can take. No, we don't have that. That's why even in POCSO many a times, if it is a perpetrator is from within the family, but then many a times you tell the parents, but they say, what can we do? We are totally dependent on this family. We are on the roads without their help. So that is why we should also know the stark reality in which we are functioning. The best of the rules cannot give us the support unless they have a support mechanism for women and child welfare. And if that being the strongest part in the system, then the forensic can do their best to give justice. Otherwise, right now, that's also a weak spot. Now, conflicts and wars have existed in the history. Rape and other kinds of sexual violence have always been used as weapons to subjugate the other. We have read about the mass rape that happens, and also the entire 2012 issue on gender-based violence, the arguments, and the POCSO Act came after the Nirbhaya case. Yes. I won't go into detail due to paucity of time. Recent Manipur violence of sexual assault, parading women naked, using women as tool of war and conflict. So often we have been doing this, using women as just objectification, objectivizing, and trying to show a community that you're powerless because we can do this to your women. Genocide, sex slavery, subjugations are not new. So domestic violence, physical and mental, psychological violence, and especially I think atrocities are heaped on women from womb to tomb. And even after she dies, many a times, she doesn't get a decent burial because they want to make a shortcut. Many of them say you can use the body somewhere because we don't have a place or a time and the inclination to take the body back. So atrocities are there, and they're cultural, they're social, they're systemic. Whatever be the reason, we are not going to go into depth, but how it impacts, I'm going to talk. Emotional violence, sympathy, care, which is required, but it's deprived of. Financial violence, where even the wife is an earning member, the money is taken off the moment she gets a salary. It's handed to the husband. Intellectual violence, denial of right to take a decision, whether you want a child or no. I was a medical officer in a postpartum center. I advised contraceptions to the newly married couple and also those who delivered. So one of this thing was to ask for ladies to undergo tubectomy if they already fulfilled their obstetric career, like 3 children, 4 children, 5 children. If women are willing, I used to create opportunities. So in one such case, the family came down upon me very heavily, asking me, what right you have to talk to my daughter-in-law? We wanted 8 or 9 children. So but I said, her body cannot take it. He said, who are you to decide that? She can take it. She's different. And how different is she? She's a human person with a hemoglobin of barely 6, 7. She's already given right to so many. And she was literally weeping at us, saying that for some fluke of luck, get me admitted, get the tubectomy done. And we really did that at one particular time. They came to make case out of us, but we said, we pleaded so much ignorance. So she got admitted, we did it. Her consent was there. We didn't need anybody else's consent. She understood the language, so she gave it. So that's intellectual violence is quite rampant. Digital or cyber porn has been superimposed now. For some reason, even morphing photographs, blackmailing, and getting them to do your wish because you are able to make them do it because you put them in a vulnerable position, and other forms of violence like denial of education, access to health facility, reproductive rights, etc. Cyber violence especially is often gender-based, targeting women and girls. There's also something called a reverse porno, where they expect you to be very friendly, invite you over, and then take your picture. And then if you want to, later on when this goes off, the relation is soured, then they tell you that we have this picture. It's consensual, and I'm going to quote about it. So they're enticed into abusive relationship with helplessness stemming from the videos recorded. Violence is pandemic. At the same time, we are also living right now in a pandemic of violence. It's all around us: intimate partner violence, sexual violence, domestic violence, name it and you have it, including the violence on the aged people. So the challenge is the deep-seated gender bias and stereotypes in investigations and underrepresentation of women in positions of power within the forensic institutions. When we are trying to talk about women, we're trying to talk about them. I was told that if you're so kind, then you're not in the right position. In forensic, you have to be tough. not kind. But whoever said that, human suffering is all over. I have no shame in crying with the people who have lost their bereaved. I have no shame in crying with a mother who has lost her son, because I can identify what it is to lose a son or a daughter. I don't think it makes me less professional, because being empathetic, sharing with them, giving a helping hand and a hand on the shoulder is not being unprofessional. But what is unprofessional is you ignore the need and you literally disregard the vulnerability. And you try to give another excuse for not doing a thorough job. And that, to me, is less professional. So patriarchal notions of ownership over women's bodies, sexuality, labor, reproductive rights, that is why when you talk of abortion, you have the entire family discussing why she should not go for abortion. Deep-rooted ideas about male superiority. She will not decide this today. When I was an intern, I was attacked literally by a mob, and I had to sit below the table. I was hiding below the table between the stable covers, because they came searching for me. Where is that lady, with girl with short hair? She has asked our daughter-in-law to eat egg. And being a lady, she will not know what is correct. Probably she's a nurse. They said, no, she's a doctor. Then why is she doing this? So eggs are not allowed in Shravan. So she's advised this. How does she not know this? So this is how we have this superiority of males questioning females on a decision, on obstetric, on tubectomy, on hysterectomy, because you're young, because you don't look like them. But this is otherification is very common in every culture. And violence is thus a tool that men use constantly to control women. Legitimacy for coercion to enforce compliance, especially hitting children to tell the wife that if you don't do it, I will hit the child. And might is right. It becomes legitimate view and increasing need for assertion of individual egos and control. Increased sexuality objectification on the screen and media, it sends a wrong signal, wrong message, even to the young growing boys. They think that this is the right thing. These are the right images, and this is how women have to be treated. So it's highly prevalent in forensic when we look at women. I just feel that everybody should give them approach with empathy than saying that it's a world over phenomenon. When a violence happens somewhere, there's always a whataboutery. It's happened here, it happened there, it happened everywhere. But we are talking about this particular lady in our OPD. If you're not fine-tuned to getting to her problem, we cannot just whitewash it saying that everywhere it happens, so it's okay, now you go. So globally, 1 in 3 women face violence. And violence is an adverse impact of survival rate on the women, girls, and also for health education, health also and education. So it makes it difficult for them to be productive members of society. People, many of them have a post-traumatic stress that they carry. Globally, mortality and disability rates of women due to violence are as high as cancer rates. So furthermore, survivors of sexual assault are 3 times more likely to suffer from depression. But when they come to us seeking some solace, some help, what are we going to do? Many a times we have paraded them from department after department. Go to X-ray here, go for investigation there, a swab check here, ultrasonography there. We lose the sensitivity of the fact that there is a person who requires a care, a compassion. In fact, once I was looking at a girl, 13-year-old, who was sexually assaulted by people on a beach in Goa, 2 or 3 people. And when the police brought to her, she was sitting like that when I approached her. Then the police are telling me to be cautious. What? Don't believe her. I don't think she's raped. I said, why? What makes you think like that? No. Because see, is she crying? Is she weeping? Mm-hmm. So this is a prototype image we build in our system. We build in ourselves. And then we try to fit that the other person doesn't fill into that reflection, then he's not raped. And this has happened with a lot of our colleagues as well. When they look at the person and say he's not raped. Then I said, we are not being true to our work. Because we have no authority to say what a person behaves like. A person can be shell-shocked. He cannot express. He's even shocked beyond control to cry. And a person could just give a very embarrassing smile. It doesn't mean he's giving a smile. Look at the eyes with the pain. But as doctors, we fall short of the duty because we don't empathize enough with people. So talking a forensic doctor, what it needs to be when we look at cases, medical legal cases, we are often called, we need to look at the complaint, be sincere in our approach to write down everything, assessment and support, especially when you call for social worker to be there. If you think that the person needs to be removed from family, a thorough medical examination, a collection, and medical examination has to be sensitive. We cannot just say, remove this, remove this. And that used to happen many a times. We have a lot of other patients. You are not the only one. Don't disrobe. You have to make a person remove things on the newspaper. So you collect the evidence that's falling, like a hair fabric or button or something. So all these are very much of a sensitivity is required. Because the legal implication in a sexual assault, we are only talking about success rate of capturing rapists and things like that. But the question is, we must recognize our responsibility that what does a person need? And that has to be addressed. Even in the death investigation, all we are interested in, complete everything, complete the form and send. But embedding into the context, trying to look at it from the context doesn't happen. So we should, I'm just trying to give you an overview of the legal framework, ethics and human rights. Of course, human rights already Amar has covered. So it's just that we need to give a basic human respect and regard, uphold the respect for human person. At no point you have a right to question somebody's right to respect. You have to give the fullest respect as though you would give to any other person. And when it comes to ethics, the consideration should be privacy and confidentiality. I myself seen gynecologists talking and making fun and calling somebody to show the delivery and other things when the person is literally feeling so embarrassed and she wouldn't want to others to see. And then on top of it, you say that, oh, you have come to the teaching hospital, you have to bear all this. We should maintain the decorum of the privacy of the person. And also because it's a legal framework, we should be careful about the wordings that we use. The legal framework changes, but we're not updating ourselves. Even today, people use such archaic knowledge for examination, per vaginal examination. I can even tell you the first sexual assault examination, it had only 3 choices, box to be filled. Used to sexual intercourse, not used to sexual intercourse, rape has been committed. It's ridiculous. But when I talked, then they said, if you're so sensitive, you don't be in forensic. I always said that, why do we do potency test? Even without potency, one can still be causing rape. Be scientific. But I thought that is humbug. The examination, rounding up 200 people on the railway track because somebody was raped and murdered on railway station, do the potency test for each of them. It's laughing stock, but it still occurs.
Yeah.
So intersectionality in forensic medicine, it matters to understand how the intersectionality is used and how the justice is denied many a times. And we need to go beyond our just examination to understand the complex situation and also cultural competence. If somebody doesn't want to be examined, especially in OPD, you should give her a privacy. You don't want to ask her about contraception in front of mother-in-law, father-in-law. So this is something we should be fine-tuned to, and we should challenge our own bias. 2 days back, I was also in the National Medical Council. We were talking about making a module. So I was asking everybody, look into yourself and come up with one bias you've had. They started with the notion we don't have. But later on, when we had an in-depth discussion, everybody could label 1 or 2 biases. So it's up to us. We should reflect on our own bias. What is it that we strongly believe it is without even having much knowledge about it? So intersectionality, we have already talked about, especially in relation to transgender individuals. We have to unlearn what we have learned as a cultural practice, what we have learned from our elders, and we have to believe that all human beings are equal. And we should mean it. We should show it to ourselves by our actions. It's not enough to just mentally agree, but not from heart. So, and also marginalized people, what it means to be deprived of everything, and what more can we do for them? So it's the challenge in forensic medicine today is access to medical services. Gender-based violence and the survivors may face huge barriers. Appropriate examination doesn't take place. If one doesn't show empathy, even the person who is complaining totally shuts off. He's not even going to the second symptom when he stopped at the first, because he feels the person is not listening. And today, listening has become a literally disappearing art. We are only listening to the mobile, a video, but a live person, a live crying person, we are not able to listen. Just try to listen to somebody and see for 10 minutes without interruption, can you even listen? And stigma and shame that they feel about, and the more questions we are asking, and in a derogatory way, how many people you have slept with? How many partners do you have? So they are very, very loaded with value judgments and need for trained sensitive expertise. Sensitivity has to be developed, and legal hurdles, proof or no proof. We should make judges believe that you don't have to have a proof of an assault. It's the context that establishes. So a lot of these are, especially in gender-related crimes like acid attack, rape, attempt to commit rape, kidnapping and abduction for trade, and for especially flesh trade, and murder, dowry, death, harassment, cruelty by husband and relatives, outraging the modesty, including a small child. You cannot disrobe them in public. Sexual harassment, assault on women with intent to disrobe, voyeurism, stalking. So these are all these, but only question is, when they come and report about it, are we in a position to give a thorough examination, sensitive approach, good history taking, and do we have a cultural competency to do that? Because today, the future of forensic medicine is also the fact that there's huge technology advancement, and the technology brings its own burdens along with benefits. If you don't oversee what the burdens it brings, we end up being victims of that. And the innovative approach should be there, how we can best give justice. And research and evaluation do not go by stereotypical, my colleague told me all deaths are because of this, all women who die are consenting for sexual assault and now they are crying assault and things. These are something that judgmental remarks we should not make. So we should train forensic examiners. We should diversify forensic institutions in leadership and representation of every gender. And we should implement all gender inclusive policies and procedures. And we should be the voice. We should give voice to those who do not have. So this is what I would like to say. It's a collective effort from the medical field to policymakers. And in forensic, actually, when it comes to domestic violence, we are very inadequately addressing the issue. We only note injuries. We say due to assault. But so the domestic violence as a word doesn't come in our report. Even if she's murdered by her husband, we say, okay, death due to homicide or due to weapon. But we never say it by the husband because the police have to fix the blame. So as a result, the actual magnitude of the gender-based violence, death does not come to the fore. I sometimes think domestic violence should come under public health, and then the forensic should be accountable for the public health delivery systems by making the reporting more robust. So to conclude, identifying gender differences in forensic medicine is the need of the hour, recognizing role of gender justice, addressing the challenges, adopting the intersectionality and informed strategies, and advocating equity and inclusivity in forensic medicine. So these are my references, and thank you.
Thank you so much, ma'am, for this detailed session. I would request Vibhuti ma'am to provide her remarks.
Yeah. With, I think, Professor Vina Vaswani's lecture, we have completed all aspects of the gendering of health, because coming forensic is a very important evidence. Most of the time in the early part of the women's movement, we used to lose out because of this kind of the misogyny and insensitivity and gender absent approach of the medical fraternity. And I think she gave so many evidences of how irresponsible and loose talk and some preconceived notion we have about sexuality and fertility and the social positioning of women, whether they are sex workers or transgender persons, how the prejudices they work at an operational level. I think the importance of this thing is that because they are practicing doctor with sensitivity and also learning the course in ethics, I think combining the social determinants, political structures, systems and structures of patriarchy, and also the kind of legal provision that we have. And there are so many gaps that we see. both at a conceptual level and operational level. I think she has brought out succinctly. And I think this is a new area so far as the gender responsiveness is concerned. And we are lucky that we have a person like Professor Vina Vaswani to bring in both the professional expertise and the gender responsiveness. Thank you.
Thank you.
Thank you so much, ma'am. I request the participants to raise their hands, or they can write the questions in the Q&A box.
If there is hand, or even unmute and speak. There is one question already there. Aquilin John, just unmute and speak. Yeah. Hello. Yeah.
Yes, ma'am. I just wanted to know if there are any statistics or anything that you can help us with in regards to domestic violence against the oldest girl child, and how often they end up availing the healthcare system.
Domestic violence against the
Girl child.
girl child.
Girl
yeah.
child. You're usually oldest girl child or
Adolescent.
girl children.
Yeah. Actually, whenever there is a violence, especially in the family, one particular girl is usually chosen as a person to receive all the anger, and she's like a punching bag. It's also called the Cinderella syndrome, where repeatedly she's subjected to a lot of violence, and she comes for examination. And I should tell you, in forensic, we fail in our duty because we try to make it medical legal. The moment you try to make it medical legal, many a times against medical advice, they go away. So sometime back, there was this girl who came. She was abused so badly at home. It was like oil burns, and then there was this actual burns, flame burns, and there were old heel fractures, and there were injuries all over her body. And the moment my postgraduate who went to, he's a bit new in the field, and he went to call up police, they ran away. I was so hurt because they're deprived of the care now. So sometimes then my next presentation was, is making a medical legal case giving a lesser care than advised? Should you not put your priority in giving healthcare support first and then follow it up with medical legal at a later stage? But we are in so much hurry in forensic, like you first make it medical legal, as though if he goes missing, there's a huge terrorist, like a small child not being in the net. So this is how we do get cases, and examination requires a huge sensitivity. And in this case, they gave a history of still younger sister causing all these, which was not possible. The younger sister, for her to cause this on her elder sister, she had to be taller than the sister. Whereas what we found that she couldn't reach even to that level, chest level, where they could. So even around the buttocks, I think she was made to sit on an electric stove or something. There were burns on the natal, these things. It was one of the things, like, we also suffer actually for a long time. And somebody's wrong move, you carry it, you try your best, how best you can find out, and things like that. So for the first time, I thought medical legal should not mean that law should overtake medicine.
Correct.
First, every care should be given. It should make reporting secondary.
That is, we are seeing it day in and day out about POXO cases.
Yeah, that's right.
13, 14,
and
15.
also mandatory reporting.
Mandatory
Where a 17-year-old girl is a
goes against
consensual
her.
sexual
She just runs
assault.
away, yeah.
Yeah.
And especially when they have a consensual relation, teenage boys and girls, and if she gets pregnant, then it's very difficult for her. She is hidden from her parents also.
Yeah. So that is why in the girl child, she's mostly it's a girl child, unless it's also a boy, and he could be from the earlier marriage, need not be from this marriage, or he has brought a lot of bad luck, born at a different time. But otherwise, we have seen this in the girl children, and mostly the eldest or the youngest, not the middle one. Mostly, this is how the numbers in these things also we have come across. But besides that, we don't have an explanation why this. Any other question?
Thank you so much, ma'am. Any other questions from the participants?
If there are no questions, then I'd like to.
Ma'am, Vibhuti ma'am, I'll request you to give the concluding remarks for this.
Yeah, I think concluding remark for all the 4 days, I think I'm extremely happy that all 10 sessions went off very well in terms of quality of research, the erudite presentation, extremely insightful and rooted presentation. None of them were talking in terms of abstraction generalization. All the resource persons gave very strong evidences based on robust research, the arguments, logical flow of these, conceptual clarity, and the philosophical foundation based on right-based perspective, gender sensitivity. That was, I think, very important. What are the takeaways of these 4 days of deliberation? In fact, every day we have exceeded the time limit by 1 hour to 90 minutes, and still we are together. So I think it is basically because all lectures were mind-blowing. They gave us so much food for thought. We are taking away so much new insights about the medical aspect, socio-cultural aspect, the social determinants of various aspects of the health emergencies and the health conditions and health challenges, the question of putting the political economy of the healthcare system, question of health budget that we need to have, so differential outcomes whenever you have a robust healthcare system, what kind of outcomes you have, and when you have a weak and dwindling health system, you know the kind of human miseries it generates. Another important takeaway is that what is most important is sanctity of a human person, which I think Dr. Vina Vaswani has been saying from day one. And she also, the other thing is that bodily integrity and the dignity of a human person. I think that is there, and the healthcare system are closely linked. And I think that is why we have to make right to information, right to consent, listening, giving a patient listening. These are very important. And I think all 10 lectures focused on transcending the biomedical approach, understanding the socio-cultural, economic, this thing, and all of them were presented in the intersectional perspective. So the intersectional vulnerabilities of people who are in a different socio-cultural location, I think that sensitivity is very important. Being all 10 presenters, resource persons also say the privilege that we have, privilege of knowledge, privilege of degree, privilege of technical expertise. We should use it. It would make us humble. And we should use this privilege for serving the people who are at the receiving end of the system. So I think that is very important. And that critique came out very strongly in all presentations, that once you have a position of power, use your power for social justice, gender justice, distributive justice, and use your lung power, your tongue power, your power of pen, and your power of articulation for providing the health rights of the people. That is what the role of technology also contextualized in the context of the commercialization of healthcare service, that how the over-medicalization also can harm, as the Dr. Uma and Dr. Mala Ramanathan gave the examples of hysterectomy, and the question of how to make the health services robust. That is a very important challenge that we all are facing, and that won't come. And I think Amar gave so many examples of Argentina, and it won't come only by the medicos. They are important. Healthcare workers are important, but at the same time, political economy, fighting for the democratic rights of people, people's representation, people's voice, they become very important in making our healthcare. Why do you have like 20% of GDP being allocated in USA, or 7% GDP, most of 7 to 10% GDP being allocated in the European Union, or even our neighboring countries, Bangladesh and Sri Lanka, known to have a more allocation because they have health movement. How robust you make your health movement, people's voices, and health is not some concern only for the medical professionals. It is a concern of each and every one of us as citizens. And I think that is why here comes the role of the participants, who were also very proactive in all 4 days. So I think I'm really extremely satisfied that the effort which the IMPRI team has done under leadership of Professor Vina Vaswani has brought to such fruition. And I think all of us are going to be the ambassador of the gender equity and gender equality in the healthcare system. With that mission, we will be working as a result of these 4 days of deliberations. I hope that comes to fruition. Thank you very much.
Thank you so much.
Professor Vina Vaswani's last words. Yeah.
Yeah, I thank Professor Vibhuti, and the IMPRI entire team, Professor Arjun and Fiza, and then who were anchored, and the participants. First of all, I've never seen such a group which from the first minute to the last, they're glued. And that also shows the openness to learn and to be a part of this program, to change, and the change makers are right here. So I'm very hopeful that this will it will transform itself into a kind of movement, like Vibhuti Madam said, where everybody is going to take up some role. It is not the bigness or the smallness of an act, but a thought of doing something positively, constructively, will have a lot of people following you slowly. So it's always good to make a small change, and that change should happen from this onwards. So if you make up your mind where you can lend some voice, or your pen for that matter, or lung power, it will be very helpful, because all around us we see this misery. And there is something for each of us to do. There's a big work, there's a small work, but the work we must do is the near. So I think we all should focus on making the change. And with those, keeping my eye on the time, that's it. And thank you so much once again. Thank you, everyone.
Amrita, would you like to say on behalf of participants, would you like to express your feelings about the course? Amrita, you have written in the chat box. Yeah. Amrita Girish, are you there?
Yes, ma'am.
Yeah.
I'd like to, on behalf of all the participants, thank all the experts and the speakers, and especially you, Vibhuti ma'am, for being there throughout all the sessions and moderating so well and summing up everything now so eloquently. Thank you, Fiza, and the organizers also. I am not a healthcare professional, but as you said, it went beyond that medical landscape and looked at everything so comprehensively, for which I am grateful. Thank you so much.
Thank you. We feel energized with such a response. Thank you, Amrita.
Thank you.
Thank you so much. So as we have come to the end of this certification course of Healthcare and Gender Equity, an online international monsoon school program, a 4-day immersive online hands-on certificate training course, I, Fiza Mahajan, visiting researcher at IMPRI, Impact and Policy Research Institute, would like to propose the formal vote of thanks on behalf of IMPRI Gender Impact Studies Center, New Delhi. We are grateful to our experts for the day 4 session, Dr. Amar Jesani, Professor Uma Kulkarni, Professor Vina Vaswani, and Professor Vibhuti Patel, for taking out their valuable time and giving us an opportunity to learn from this online certificate program. We thank all our participants who have raised pertinent questions and actively participated in today's deliberation. We are grateful if you are watching us later on YouTube or listening to us on our various podcasts or reading our publications. We hope you continue to join in future to IMPRI Web Policy Talk and Web Policy Learning. I wish you all a very good day. Thank you.
Thank you. Thank you, Fiza.
Thank you.
Thank you. Fabulous program.
Thank you, Dr. Arjun Kumar. You deserve the, yeah, you have done the most of the work.
Actually, working with you is so easy, Dr. Arjun Kumar. We really didn't have to do anything. You just carried us all the way through.
But brilliant participant this time.
Brilliant. I'm so happy.
So
Really
glad.
worth the effort. And yeah, extremely nice.
Thank you. Thank you.
Thank you, Dr. Arjun Kumar. Now we meet after, I will be in touch with you after 11th of September.
Okay.
I have nearly 1,000 people to look after.
Okay. All the best.
More challenging. Yeah. So I'll be leaving for Trivandrum day after tomorrow, and we'll be back on 11th. So 12th
All the best, madam. All the best.
Yeah.
Thank you.
Nearly 60% new delegates are coming. We don't know them personally. So a lot of time will go in this facilitation and conflict management, whatever, language problems and all those. Yeah. So I'll be. Yeah.
Thank you so much, ma'am.
Thank you. Congratulations,
Thank
Dr.
you,
Vina Vaswani, Dr. Arjun Kumar, Fiza, for a grand success of the deliberations and the quality of material.
Thank you. Thank you, ma'am. Thank you very much.
Thank you. Yeah.
Good night.
See you. Bye.